Buenas tardes.
Good afternoon and welcome. Thank you for participating to this third edition of the Spanish National Pompe Patient Association. Many people have hopes. We have relatives, we have medical professionals and people from research with us here today. This is an occasion to continue to address the daily needs and the importance of the multidisciplinary approach for the affected person, and doors open for research to make a cure a reality. For these next 2 days, we will all be here, and we have each speaker so important and necessary in the project to improve the lives of people who have Pompe disease. This conference gives us a new opportunity to underscore the fact that from the association, and in this case from our own small but active association, we work very hard to be the voice of the affected people, and we need help for this. To organize a conference such as this, which we are inaugurating, is to address research, medical developments, therapeutic approach, and of course the life histories of the people who have this, and as well as what their relatives say. I would like to state that these meetings are a need. But to organize a conference such as this with continuity in time is a huge effort for an association like ours. We are small but very active. We wish to continue, and I am saying this, we wish to push forward, and this is why this is a moment for claims. I said before that we need help, and this is a fact. We are associates. We need initiatives which will help us to generate resources from the institutions, from entities, from the pharmaceutical industry, and from enterprises, so they have a social responsibility, and also we need the help from the third sector. If we are able to work all together, we shall be able to be a voice and support to accompany and to help to be a small but active association. I wish to give special thanks to all of the people involved in the organization of this meeting, its development, and to the professionals who are with us, to the speakers who shed light upon this disease. Thank you for confiding in Pompe. And we are going to be together, and we shall continue to write the history of Pompe, Spain. And for these 2 days, we will hope that they will be more. This will go to the future. This is a prelude for many more conferences. Thank you very much.
A continuación,
And next, Juan Carrión has the floor. He is the president of the Spanish Federation of Rare Diseases, FEDER, and he is going to give a virtual presentation. Thank you very much. Thank you very much for the invitation extended to the Spanish Federation of Rare Diseases to participate in the third edition of your conference of the Spanish Pompe Patient Association. I can't be with you personally today as I would have liked to, but I would like to give you all the support to your Spanish Pompe Patient Association. And dear Alejandra, President of the Spanish Pompe Patient Association, to your team, congratulations, of course, to you and your team for having organized this conference, which will enable us to learn so much and to share information with different professionals. We have researchers, we have research, and the patients and the relatives. We will all learn from one another. And we know that this is something that all brings us together when we speak about rare diseases and infrequent diseases. And I would like to thank Manuel from the Spanish Federation of Neuromuscular Diseases, ASEN, because we know that you've worked very hard. And by the way, I know that in a few weeks you're going to celebrate your 20th birthday. I would like to tell you how thankful I am for what you do. And I know that you're all going to be participating during this 2-day period, and you're going to be learning so much, which the Spanish Pompe Patient Association has prepared and what we will learn from. And we're going to be able to share these issues and challenges that we all face. And we know how difficult it is to diagnose these rare diseases. And particularly Pompe disease is always very difficult to diagnose, and we want to continue to share what is coming from research and so forth. We have new therapies, and we must go forward and progress, of course, because we also have to have hope. All of these patients must have hope, and when we have an orphan drug, we want it to be available to us, and we need to have access to these orphan drugs. So in a nutshell, this is a big challenge that we have as a federation, and we need to all together defend before the administrations, defend our needs, because ours are yours and yours are our needs. And this is something, as I say, we should do together. And of course, for me and for all of those who are in this large group of people with rare diseases, and in Spain, we're more than 3 million people with rare diseases, and we know what it means and how important it is to invest money in research. This is the future and hope for anyone who lives with one of these more than 6,152 rare diseases that for the moment have been identified. Congratulations to the Spanish Pompe Patient Association, to each and every one of these people who are part of this group, and for the work, the extraordinary work that you do. And I would like to congratulate you for being able to respond to the needs that these patients have. This is very important to remember this. We, of course, need to be able to speak about the future and have a future with hope for all of us, for each and every one of us, to be able to witness what is going on. And we see that there are many important announcements made lately in our country about, there are better public health policies to improve the lives of our people. This is something that we can feel, and it will, of course, bring us a brighter future. And, of course, we know that we need to feel those results. This is something we actually kind of can touch, shall I say. And we work together so that everything will be a reality. And we want to make the most of all of this information and knowledge. And I know, as I say, you're going to make the most of everything that we learn here from our extraordinary speakers who are going to enlighten us. And from the Spanish Federation of Rare Diseases, this huge family with more than 420 organizations in the country, that we will be by your side in order to be able to share our knowledge and, of course, to continue walking this path together.
Para concluir,
To conclude this inauguration ceremony, we shall give the floor virtually to Manuel Riego. He is the president of ASEN, the Spanish Federation of Neuromuscular Diseases. Virtually, I have no doubt that on future occasions we will have the occasion to be together in person. It is a pleasure. Hello, one and all. Hello, one and all. In the first place, I would like to address the organization and, above all, the president of the association, and to thank her for having invited me to participate in this inauguration ceremony, although for now this is virtually. I'm sure that in future occasions we will be able to meet in person. In order to be with you in this inauguration ceremony of your conference for the ASEN Federation, the Spanish Federation of Neuromuscular Diseases, as I say, it's very important, and we wish to share important moments for you and for us. These are associations, and which is, in other words, the organization of your conference. This is a conference which has an extraordinary program prepared for everyone. And also, I would like to congratulate you for your objective, your aim, which is so clear and so necessary. The aim is to bring together researchers with the patients. Research which on many occasions forgets about the most important part, which is the patient, the person, in other words, for whom research is being done. And it is vital for that person to have this research and these developments. And sometimes we are forgotten about, left in a corner, as if we were just a little statue cast off into the corner as a decoration, when in fact we are the most important part of all, because research for a patient without the patient does not progress. It doesn't move forward. It helps no one. So we know about our disease better than anybody. We are familiar with the symptoms. Some are affected more, some are less so. But no one knows more about this, even though we see a lot about this in textbooks, because we, the patients, are the ones who feel this in our own skin. And this is why it is extremely important that the researcher meet the patient in person. Personally, this is why I'd like to congratulate you for your objective, your aim, because this is a singular space and an opportunity, which I do hope there are many of these, and that you will have research that will go hand in hand with the patients and with associations which represent the patients, because this is an important moment to go ahead and to go hand in hand, as I've been saying, to join forces, in other words. We need to walk together, as the ASEN Association said and the Pompe Patient Association said. We need to stride ahead together. We need to knock down the huge walls which we find along the way, those of us who have a neuromuscular disease in Spain, or disorder. And so we've been, well, actually, we've been on the 17th day of November. It will be our 20th anniversary of working. And we have a long way to go. But personally and hand in hand, we can do this together. The Spanish Federation of Neuromuscular Diseases began working as an association, and then it was changed into the Spanish Federation of Neuromuscular Diseases. So that's been 20 years now. The 17th of November is our anniversary, and this is a very special anniversary for us because throughout this 20-year period, we have gone through many turning points, and we, above all, in this last period, we've lived a series of circumstances which have complicated our lives for patients' associations, of course, more so with people. We've had pandemics, and at the moment, a war, and this has a repercussion on everything, because sometimes it means that patients are forgotten about, the vital function which we associations, patient associations do, and the Spanish Federation of Neuromuscular Diseases works every single day to try to make the work visible, this wonderful work that is done by your 32 entities. We need to make this visible, as I say, and thanks to which we have been knocking down walls. But as I said, we have many other walls to knock down, obstacles to overcome, and we have basic rights that should be recognized to have that we have access to continuous physiotherapy programs, that we have good assessing of the degree of dependence, and as I've been saying, it's important to have a quick diagnosis and an efficient diagnosis, and this would certainly facilitate the way we can cope with our diseases, and we could plan our future as persons, and above all, to be able to be familiar with our disease and to make more progress, and that we can walk hand in hand in this future, and with our progress that will undoubtedly occur. And as I say, there will certainly be in this 20-year period we've grown and we've moved forward, and with our Spanish Federation of Neuromuscular Disorders and also our Spanish Pompe Patient Association, we work together. We're all making significant progress, and we're going to progress and move forward together. Thank you very much for being part of the Spanish Federation of Neuromuscular Disease group. Well, thank you very much once again for all being here, and this third conference for Pompe disease patients stands inaugurated. We shall begin our program with the round table that we call Respiratory Involvement in Pompe Disease. You know that early onset respiratory problems, our muscles are weakened, and alteration of coughing leading to pneumonia, repetition pneumonia. This also affects swallowing, causes apnea, lethargy, snoring, and other things. How do we approach respiratory involvement in Pompe? And respiratory failure as the main cause for morbidity and mortality. And where are we to approach these respiratory infections in Pompe? We now welcome Dr. Barbara Smith from Florida University, and she will chair this session with the participation of Dr. Ana Hernandez from the 12th of October University Hospital and Dr. Jesus Sancho from the University Clinical Hospital in Valencia. Thank you to the three of you, and you may come up to the table. Thank you.
All right, thank you very much for the opportunity to join you here at the third Congreso. You know, I can't say any of those words up there, right? Thank you. I really appreciate the opportunity to be here with you from Florida and to join two experts, one from Valencia, one from Madrid, and they're research and their clinical expertise that they provide in Pompe disease. And so perhaps first, maybe each of you can share a little bit about what you're working on, the care that you're providing, and your interests. Is that okay?
Sí, hola.
Yes, hello. I would like to thank the organization for this invitation. Thank you very much. Well, I am a pneumologist from the mechanical ventilation unit of the 12 de Octubre Hospital in Madrid. It's a usual reference center of neuromuscular pathologies and with Pompe patients as well. We dedicate mainly to respiratory support with mechanical ventilation, but we also have several research lines with respect to this pathology specifically. Well, good afternoon. I also would like to thank for this invitation to be able to be in this Congress. I'm Jesus Sancho. I'm the coordinator of I'm pneumologist as well. I'm the coordinator of the respiratory care in the pneumology hospital of the clinical hospital in Valencia. It's a reference unit that in the Valencian community for managing the respiratory problems at large in neuromuscular diseases. Our work is focused mainly on the control and the management of the respiratory problems in general of the neuromuscular diseases, and we also include patients with Pompe disease.
Thank you both. And so Ana and Jesus, we discussed in advance of the conference how best to coordinate the roundtable discussion, and really felt maybe more of a conversational tone might be the best. I think Manuel just said it very nicely, right? That our participants here in the conference, you're not statues in the corner, right? You are the experts in your own living condition. You are our partners and our stakeholders, both in research and in clinical care. And so we've come up with a list of things that we think maybe are vital to the patients that we work with. We'll discuss some of those factors, but we also welcome some conversation. The first thing that we'll go to is discussing the topic of sleep. And of course, we spend almost a third of our life sleeping, so it's sort of an important thing for all of us. And in many instances, the symptoms of respiratory insufficiency first become apparent as problems with sleeping, and we want to acknowledge that and maybe discuss a little bit why sleep can be problematic for people with Pompe disease. So would either of you like to maybe elaborate on why sleep might become a problem?
Sí, bueno, a ver.
Yes. The patient with Pompe disease is particularly complex as to the sleep pathology is concerned. It adds something more to the traditional sleep pathology. Well, usually, nor Jesus nor myself dedicate exclusively to sleep, but we nevertheless have patients with Pompe disease that in turn have sleep disorders. In Pompe disease, the peculiarity is that apart from the diaphragmatic involvement, that is also what is most concerning for us, this is the first cause of death, is the respiratory failure in Pompe disease. And this is in reality what we dedicate much more time. The patient with Pompe disease is more complex because not only does it involve the respiratory musculature, but it can also produce weakness of the oropharyngeal musculature. And that's why having weakness in the oropharyngeal musculature, it can be a sleep apnea syndrome, as is the usual one. This is an obstructive sleep apnea disorder, most of the syndromes that exist right now in sleep apnea. But apart from that, in Pompe, it has also been proven that there can be involvement of respiratory centers at the central level. So there can be obstructive sleep apnea, the classical one, but also central apnea of the sleep that is harder to manage. Apart from the fact that it can be a sleep obstructive apnea due to weakness of the oropharyngeal musculature and collapse when we are very fast asleep, and central apnea of sleep
That is because the neurons of the central drive of the respiratory center do not issue the signal of breathing during sleep. And also the peculiarity of the macroglossia adds another problem, added problem. Sometimes there are obstructive sleep pathologies not due to weakness of the pharyngeal musculature, but due to a macroglossia, especially when the patients are lying in prone supine decubitus when there is more obstruction. So the sleep pathology in patients with Pompe disease is quite more complex than mere sleep apnea syndrome. That is the usual thing that we see. And we have several problems in managing it as well. I don't know what your experience is, Jesus. Well, practically what you have said, and I just would like to add something. Not only in the sleep obstructive sleep apnea, but if we focus on the problem of the diaphragm, the main muscle that is will be involved by the Pompe disease at the respiratory level, the main signs or repercussions are going to be on sleep, although the patient is asymptomatic at daytime. In general, everybody during sleep breathes less. There is an alternating of phases throughout the sleep, and there are specific phases where the activity of the breathing depends only on the diaphragm. In patients where there is a weakness of the diaphragmatic muscle, as is the case of Pompe's disease, this is going to make that during that phase of the sleep, the diaphragm doesn't have enough strength to work as it should and produces what is called, apart from the obstructive sleep apneas, pictures of hypoventilation. There is low oxygen in the blood, and the carbohydrate starts rising when the patient wakes up until the disease is not more advanced. We don't see the symptom derived from that problem, from the respiratory involvement. But in many patients, long before, we do have those problems at nighttime. So it is very important, and hence the endeavor, especially done by the studies made by Anna with different techniques to detect on an early phase this involvement of the respiratory muscle, because as she said, the patients during the daytime are asymptomatic and they say, oh, I'm breathing well. But you make a study at nighttime, during the night, how he breathes, and we see that the problems may starting appearing.
Thank you. We know that some of our participants have in their pulmonary care have received sleep evaluations. Others have waited a considerable time to receive a sleep evaluation. And just I wonder if you can comment a little bit about maybe clinical tests or some of the research that you're doing that might cause a provider to detect that there could be a problem and to prescribe a sleep evaluation, and what that process is like.
I have several slides I'd like to show you, if I may, concerning the results.
No sé cómo... yo veré, perfecto, ya está. A ver si abro aquí. Es corto, prometo no extenderme. Pero
This is short. I won't go on. This won't go on long. And we've already heard frequently that respiratory involvement, as we heard at the beginning, and as we already know, that this respiratory involvement in Pompe disease is the first cause of death, with which it makes quite a lot of sense to get a clear diagnosis and then firstly evaluate the respiratory musculature, because this will determine acute respiratory failure, which is the main cause of death. And besides, it is the main cause of hospitalizations with respiratory infections arising and things like that. And I think this is quite important here. So let us look at the respiratory musculature. The pneumologists, in this sense, have the problem because the tools available to us are not sensitive enough. This is it's a revision from different respiratory functional tests in patients with Pompe disease. And if you look here on the left-hand side, you see the spirometry, etc. You can see all the tests that we do. And within this little red rectangle, you will see on the left-hand side the sensitivity to these tests, which is quite low. And on the right, the specificity. What does this mean? It means that when a patient does these respiratory functional tests and when they're done not so well, they won't be very good. But a lot of patients aren't very well. They do not have changed results, and one might not detect a respiratory involvement in time in order to begin adequate treatment. So this is what Jesus was mentioning. Here we need to find tests and find proof that not necessarily more specific, because the ones that we have are already specific, but they must be more sensitive. In this sense, we have a study developed where this is being carried out in the 12th of October hospital, our hospital, and this is a follow-up of a series of Pompe patients with respiratory problems. We do this every 6 months, but we add a bit more. Specifically, we add, this is the SNP and also capnography transcutaneously. And these are novel, they are sensitive, and these detect high alveolar hypoventilation, as Jesus said. And tomorrow, if you can do these tests, I'll explain this in person and in greater depth. And look at the muscle here. And then you see a video of how the diaphragm thickens. If those of you aren't too familiar, but I'll explain this in greater depth. Tomorrow, thickened diaphragm. And this is very interesting here. And during this follow-up, as been described in this entire series, there's a progressive decrease of the FVC. That's the most important. We know that the forced vital capacity is very important. That we need that. This is very important. When he's lying down, it increases. But when we've seen in this particular series, as that the SNP is a specific test, as the fraction which the ultrasound gives, and it drops before 6 months beforehand, before is done when we see this in the FVC, forced vital capacity. And so we suspect that these would be more sensitive techniques in this sense. I wanted to complement something Anna said. Most of the studies made not only to assess the respiratory involvement and problems of Pompe patients and the disease, but see the efficacy of the drugs. And so these tests that Anna spoke about are used. We have the vital capacity. It's important to do, but when it's altered, the patients they've already re-evolved, and we don't detect all of those patients where there might be an involvement of the respiratory muscles, and with which I would think that the study should focus on more specific tests to detect much more early on the respiratory involvement, and to see the efficacy of the different treatments that are being developed for Pompe disease, and to see the results on respiratory function. Perhaps this will explain the results that we have, for example, when we give a substitution therapy, enzyme substitution therapy, replacement therapy, and most of the studies say, oh, it's stable. We don't know if any. Others say it improves, others it worsens. Well, we're going to have to, maybe if we had more sensitive tests, then we would see the repercussion that it really would have on the respiratory musculature.
About this, in that the tests that sometimes accompany a scientific study or a clinical trial are not necessarily reflective of what the respiratory muscles do every few seconds when we don't think about it. These tests are maximal effort, they're effort dependent, they're learning dependent, and so indeed, I think looking more closely at what the respiratory muscles are doing naturally, whether while awake or as discussing while our patients are asleep, and whether the ventilation is sufficient during that time. They're telling us maybe two different things, and maybe we need to take a closer look at both of those things and not just one.
Sí, probablemente es mucho.
Yes, surely. We don't try to do away with spirometry. It's a very specific technique. It's been described and used for a long time now. But it is true that spirometry is done when the patient is sitting down, awake, completely awake. So for someone yelling at you, do this, do that. So it's not the same situation that a patient might have during that person's sleep. It doesn't really make much sense. Not only we should, to diagnose the respiratory involvement, and as Sue says, monitor the response to the treatment, and if it has to be sensitive, because maybe the problem isn't with the treatment, but in the tool that we use to measure the response. In fact, in our daily practice, when we see patients, not only do we evaluate them using spirometry, but also we use many other techniques, which as a whole will give us information about the true, real situation of the parents, from the patient's symptoms, own symptoms, that spirometry, obviously vital capacity, in decubitus, muscle situation, ultrasound. This is being used now in all of the practice of pneumology, and this is a very valuable tool for us. And at nighttime, we need to have possibilities to do this at home, thanks to different companies that supply this. And so we don't necessarily, in the past we had to put a lot of cables on the patient and wires and all to make these measurements, but now it's easier done at home. And now we can, a very important aspect would be the muscles, which will enable us to take the mucus out, Because if these muscles don't work well, just a mere cold will cause problems. It's this mere cold. Well, if this person with a cold and goes onto the street, and a person with Pompe disease, it could cause claudication. That person would go into the ICU with respiratory failure because that patient couldn't bring out his or her secretions. So it's very important to evaluate the capacity that those muscles the respiratory muscles have to be able to allow a person to cough, to allow that person to expulse that mucus when a person would have a cold, for example.
Now, the scientific literature, I want to ask this question because this has come up a few times, even just this year. The literature indicates, of course, using ventilator support is a balance. Really too little will not correct our hypoventilation. It will not support central apneas. But on the other hand, excessive settings may make the patients feel that their natural breathing is not synchronized. And that can create disruptions. So when the prescribed settings match the patient's need, it helps to promote the deeper sleep, prevent hyperventilation. And so what is your approach to making sure your patients are comfortable, and what symptoms should warn patients that they may need to speak to their physician about adjusting their ventilator settings?
Bueno, para empezar.
Well, to begin, the patient with neuromuscular disease, particularly Pompe disease, is never far from the pneumologist. That person always is seeing a pneumologist and usually sees the same team. Once the respiratory failure has been defined and it needs support with BPAP, it's not given that. BPAP must be titrated, and it must be retitrated whenever it's necessary. Whenever it is necessary, it's important because it's not a static device. But when the disease progresses, and it will progress with age and weight changes and so forth, then we must monitor, reprogram that respiratory device. So there are simple things that we can do. For example, patients with Pompe disease, even though they are being treated with BPAP, they need to follow functional tests. They need to do the functional test, the respiratory functional test, because not only do we detect this when they need the BPAP, but we need to see how the patient, how the rhythm here. In each review, we have a tool, and it's simple. It's this respiratory software. And I would like to say that in Spain, Jesus, correct me if I'm mistaken, we review the software of the respirators, that this monitors the flow and pressure curves the patient makes. We see this in our office, and we can see how the patient is breathing, and we can quantify the volume of air going in, the pressure going in, if the air escapes, and so forth, even if the person wears this device. And this could be monitored continuously. And there are degrees of monitoring which are sometimes more complex depending upon what the patient needs. The last degree of monitoring is that sometimes it's necessary to directly, the patient should go into the hospital to use electromyography, esophageal probes, and more advanced types of devices to monitor this. We don't not only indicate ventilation, but also we have to see if the patient, in fact, has efficient or deficient alveolar function during the night. If there's any incidents, the patient must call. Sometimes if the patient is sleepy during the daytime when that patient was not sleepy beforehand, because this might mean that the disease has progressed and now the patient needs more pressure, or air is being expelled, there are leaks, and enough air is not going into the lungs. But regardless of the fact that the patient has symptoms or not, the follow-up should always be continuously done, even in patients who are asymptomatic. I would like to add an important thing that Anna mentioned, and that we see the ventilators and we need to correct the parameters because of one very important thing, because the disease progresses. And it might be that during the night the ventilator is okay, but the problem be that the disease has progressed, the weakness of the respiratory muscles is greater, and so what the patient in fact needs is not only to use the ventilator at nighttime, but also to use it during the daytime. And here there are different ways to send air using different types of masks, so that we be able to help, and in very advanced phases, we be able to substitute the respiratory muscles when the disease is already very advanced, and during the daytime the patient is not able to even breathe correctly.
Okay, thank you. You mentioned transitioning maybe more into some use during the daytime, and maybe some different options with how support during the daytime is addressed. In your experience in Spain, there's some use of this in the United States. What is your approach with using devices to improve recruitment of the lungs, the lung volume recruitment here in Spain? Is that something that you can comment on?
What you said is very interesting, because this is another problem that we have when there is weakness of the respiratory muscles. Under normal conditions, everybody, without even realizing this, every single day we breathe in. We breathe in and our lungs are completely filled. We don't even realize this, but we filled our lungs up maximum, laughing, coughing. This enables us to maintain the lung elasticity of the lungs and the chest. Let us take a balloon, which children use. We will leave it a few months without blowing it up. We just leave it on the table. Then we take it, we try to blow it up, and we cannot because it's stiff. And with the chest and the lungs, the very same thing happens, with which, as she said, there are a series of pulmonary recruitment techniques enabling us to get the maximum capacity of breathing in order to maintain the elasticity of the lung tissue as well as the chest and the joints in the chest cage. And here, in my experience, we use breathing in with the manual resuscitator, and we have different moments of bringing in the air. If the patient cannot fill in up his lungs, then artificially we're going to fill that patient's lungs up. We're going to blow them up, in other words, to a max, with which we're maintaining this elasticity. And another technique we use, and this is with the ventilators and with the air from the ventilator, instead of doing this manually with the ventilator and with the mechanically assisted cough, great volumes of air and fill up the lungs to a maximum and have good tissue tone. It's also true, and what's going on here in Spain, what happens in different autonomous community, but we know that in Madrid we have a deficit with public help of respiratory physiotherapy. Our patients, for example, who have physiotherapy, and they should all have this, not only if there is a respiratory involvement, but before there is, in fact, this problem. But in our public hospitals, we don't have enough of this to help us. Physiotherapy, and patients have to find physiotherapists who are in private practice or devices and AirFit and different companies. And this is muscle training. And this is monitored by professionals. And there's a great deal of deficit here. I don't know what the air experience in Florida is with this.
Yes, so certainly in the United States, we maybe have different issues with access in healthcare and physiotherapy provision. And so our insurance situation is quite heterogeneous, and in many situations, a respiratory physiotherapy is not universally covered by an insurer, which can create some disparity in access to the physiotherapy. With that respect, then prevention and education become paramount with our provider access points, so that patients receive the equipment and the education that they may need. Because there may be just short periods where the physiotherapist is able to work with the patient so that independent routine can be established for patients. And so I think in that respect, finding a routine that is not just of course evidence-based and scientifically recommended, but also feasible for what the patient is able to do, for their resources, and not just financial resources, but their time resources, and what is able to work within not only meeting their respiratory needs, but then the other commitments the patient may have. And so I think that's where we don't always have a lot of time to work with the patient to find that balance. But I think it is crucial to work together to understand what it is the patient might be able to do with respect to committing to preserving, their committing to a routine that may help them to preserve their respiratory function.
I think, Ana, that not only in Madrid but also in all of Spain, there's certainly a deficit of physiotherapists. Here in Valencia, we, the pneumologists, are the ones that devote part of our time to doing the work that the physiotherapists should do, in fact.
Speaking a little bit more about physiotherapy, about exercises, there have been some smaller trials in the literature that indicate respiratory strengthening exercises might help preserve breathing function, both in younger patients as well as individuals with adult onset Pompe disease. And our group has a little experience with this, but I would like to hear about just the use of respiratory strength training in Spain, whether that's something that's accessible to patients or whether other exercise approaches are used maybe to preserve breathing here.
Ese es el problema.
This is the problem. We don't have enough physiotherapists except for very specific programs where there are more investments and in a neuromuscular area. Well, we really don't have enough expert physiotherapists for this. For physiotherapists in our hospital, the pulmonary care in our hospital, there are a series of professionals who help improve the respiratory function of these patients as a bridge to the transplantation. It's not possible for patients with neuromuscular pathologies and for many other patients as well. So unfortunately, what I've heard from my patients who do get good results, they use training devices which are linked to applications they have on their mobile, AeroFit, because not only is this a variable pressure device for inspiratory pressure and diaphragmatic training, but also the app designs a program, a timetable, and charges. They increase the pressure little by little and reminders and this and that. The fact is that these are very specific experiences. Unfortunately, I can't tell you about too many experiences with rehab programs. We would certainly like that, but it's not the case. There's a long way to go here.
All right. Well, it sounds like we just need to get a sabbatical for me to come and join you in Madrid for a year or two. Yes?
You're very welcome.
Yes? Okay. Wonderful. So now, Jesus, as we prepared for this conference, you brought up an issue that I think is very important, and that is respiratory drive. And, there is evidence that as, respiratory muscles gradually become less effective, that the drive to breathe, can become impaired over time. And that, perhaps asymptomatic Pompe disease, really should be reconsidered, because maybe there are subtle signs that could suggest that our patient their disease is progressing. And so some of this overlaps with some of the concepts we've already discussed, but how is this apparent in your work with respect to the asymptomatic patient, and how do you approach the patient who otherwise is ambulating well in the community, is still working and managing their family, but how do we manage and make sure that these subtle signs are not missed?
Como si el paciente está asintomático, ¿cómo podríamos detectar que tiene disminución del drive?
Sí, sí. Pues.
Well, we need to get all of the tests by trying to analyze very carefully asymptomatic patients by looking at the blood gas exchange, and we see the bicarbonate because there might be blood gas exchange, but high bicarbonate, and this is indicating that there are nighttime problems, which mean that the bicarbonate go up at night, and whilst the patient is sleeping, it's different, and when he wakes up, he's normal again, and we can, instead of checking a certain value in a cutoff point to see their vital capacity, I like to see how everything is evolving as time goes by. If there's a sharp drop or just a progressive drop, for example, and to also compare this with measured vital capacity. in supine decubitus position. And we look at the diaphragmatic ultrasound because, as we're hearing, this is being introduced in all of the doctor's offices. And if there's a minimum suspicion, we do a nighttime study. Sometimes we can do this at home, these tests at home, and our capnography, as I mentioned before, to see if a patient has, well, we see what the different, we can see that with this capnography, and we, as I say, we can see the situation of carbon dioxide at night and day and all. Thank you.
Sí, otra cosa es que
Another thing is, at any rate, even in patients who don't have respiratory and muscular involvement, but they do have involvement of the central drive, these are patients who might have central apneas. And not only are they difficult to diagnose, and for this we need to have polysomnography. This is a sleep study, but also with an EKG, and we can do this we can see that the problem is, the thing is that we don't even have a very effective treatment in this sense. For example, new technologies are being developed, and they're not really too developed yet, but new respirators, and they're servo respirators, and they use a little bit of artificial intelligence to respond to certain stimuli. This is still very, shall we say, we don't know too much about this. We don't know as much as we do with the CPAP, but this is something that is being done. All these respiratory pathologies of central origin are very complex to diagnose, to treat, and to follow up. In Pompe, unfortunately, Pompe is one of these areas. In fact, the possible techniques that we can use to evaluate, to see if there is this that can cause respiratory drive problem, these are problematic to do as well as to interpret. It would be important to be able to go ahead in these topics, these issues, because this drive alteration is something that we find which is interfering with the good functioning of the ventilators when the patient is using the ventilator at nighttime.
Thank you. And something that I've heard come up during our conversation here, a few things about maybe what also alerts you, things that the patient may tell you, such as becoming more sleepy during the daytime. I think we talked about waking up not being restful, maybe having a headache, frequent awakening, not frequent disruptions in the sleep cycle. There was also an interesting study. It was a assessment of Pompe disease, sleep. Several years ago, it was a study came from scientists in Italy. But in addition to these symptoms, they found that patients who are hypoventilating at night also woke up more often and felt, when they awoke, they thought maybe it was perhaps because they needed to use the restroom to empty their bladder. But in fact, it was, they found that those patients who were waking up more frequently to use the restroom had the lower, had the lower ventilation, had more nocturnal hypercapnia. So maybe sometimes we as individuals, as patients, wake up and don't necessarily understand why we've awakened, but that we, in fact, maybe need to discuss that we are just awakening more at night if that's a problem, rather than assume that it's one thing versus another. We also brought up earlier that, of course, effective ventilation is clearly imperative, but another essential role of the respiratory muscles is protecting the airway. And clearing mucus or any other contaminants from the airway. And so in your practice, how do you evaluate cough and make sure that the forces generated to clear the airway are sufficient?
Bueno, esto habitualmente.
Well, this usually, we don't need to ask about this much because this is very striking for patients, and they usually tell us about this. And for example, they say, I cannot get rid of my mucus. And even the wife or the husband or however they say they just cannot they cannot expel that mucus. And these are problems which exist for a long time because they can't cough. They cannot bring out their mucus, their secretions. This tends to be a symptom which the patients talk about even before asking them about it, but this should always be monitored. The test to evaluate the inspiratory musculature, which is we're most worried about because of respiratory failure, they're not the same tests which evaluate the expiratory musculature. So within the maximum pressures, the PIM evaluates the inspiratory musculature, but the PM does it with the expiratory musculature. And we do not breathe with the diaphragm. Expiration is done with the abdominal musculature. So the way to evaluate this would be a maximum expiratory pressure. And as far as I'm concerned, it's much more practical to have a COS, to see what the COS peak test would be more simple. This is a peak flow, and this is something, it can be homemade, shall we say. It can be done, an asthma peak flow. You get it in pharmacies. All asthmatics have one. And you can use a mask because it's very difficult to cough into a tube, of course, because a lot of force is lost. But with a mask, we just ask the patient to cough, this cough, and this. It's not very precise, but to measure the cough, but it should be done with a calibrated pneumo tachographer and a turbine. But I can say that if the patient's cough we can just see if this cough is efficient or not. And more than 240 liters per minute. And this is nothing more than just a cough to see how far the little peak flow device moves. And then we see the patient will be able to expel secretions when he does have them. Usual dose is around 400 liters per minute above the threshold. And with less than 240 liters per minute, this would be considered, even when the patient does not have any problems with secretions at that given moment, because precisely that moment there's no secretion, but maybe 1 week after the coming that there might be mucus and phlegm, then there should be some technique should be evaluated to check the dose mechanically or manually. However, this is a functional test as any other, and this should be done and each time the patient comes to our office. In fact, we and all of our patients, not only Pompe patients, but in neuromuscular diseases, when we see them and each time they come to see us, besides studying their vital capacity, blood gas exchange, we check the cough peak flow. And we saw, since the 1950s, the cough effectivity, to be able to take out this, expel the secretion depends on this airflow that is generated. This maximum flow that is generated during the cough is the cough peak flow. And it's very simple here. When the patient blows and does spirometry, we say cough, and just in a moment we measure this. And as Anna says, this is evaluated, and after a given moment, even though the patient might say, no, I'm coughing just fine. Yes, but there is a cutoff point, a cutoff when the cough is effective or not. No, there's a very simple explanation here. We have all experienced this. When we have a cold, we all feel horrible, we're tired. It's because there's these respiratory infections, there is muscle weakening, and even with the respiratory muscles. So I'm a Pompe patient who is weak, and that weakness, it gets worse because of the infection. And then 20-some days go by, and this drop, it's a sudden drop. It drops in 24, 48 hours of the strength of the respiratory muscles might mean that a cough might seem to be effective, it might become ineffective, and it might mean that if a patient has a cold, that he would be very unwell. So almost all of the times, one must use techniques, assisted cough, even when the patient might say, well, I cough okay, or we're seeing values where we know that the cough is or is not effective.
And that preserving our cough force is one of these habitual things that needs to happen, because we can't necessarily predict when we may become ill and weaken. I think another thing to bear in mind is that in a coughing effort, there are typically 3 phases, and the first phase is to take a deeper breath than normal. So while the forces generated, the expulsive forces, I won't do that in the microphone, while those are of course expiratory in nature, we take that larger breath in, we bear down, and then we expel the air. And so those other portions, the other inspiratory muscles, the airway closure muscles, those need to coordinate well in addition to the expiratory muscles. And that may be something where our patients who are not generating as effective an inspiratory effort, maybe the cough assist device also can provide assist not only with the expulsive effort, but to help generate improved volumes at the starting point of the expulsion. Any other comments on airway clearance cough? Okay, there are a couple of just hodgepodge things that I know came up in our emails in preparing here that I just wanted to throw out there. Sometimes we receive questions about other pulmonary therapists. So, for example, I have trouble breathing sometimes, so why hasn't my doctor prescribed oxygen? Or would an inhaler help my breathing? Any thoughts that you might have to share on those matters?
Sí, sobre todo porque hay pacientes aquí.
And above all, because we have patients here with this situation. The difficulty to breathe is not cured with oxygen. In neuromuscular diseases, it is possible that sometimes oxygen is needed, but it tends to be transitory because of a respiratory infection, or the patient might have an important comorbidity such as a COPD or emphysema, and then besides having Pompe, but that was very strange, but that could be the case. Excess oxygen produces an excess of carbon dioxide retention. So if a patient with neuromuscular disease has weakness of the respiratory muscle, it is not a problem because of gas exchange. It's not the pulmonary tissue which is being affected, it's the respiratory muscles. So this is a mechanical problem. We need to put in air and pressure in order to inflate the lungs, but with the amount 21% oxygen, which is what we are all breathing right this minute. But when we give oxygen, of course, you put the pulse and the oxygen goes up, but you're not correcting the problem. You're just increasing the amount of oxygen you're giving to the patient. But you are not only are you not correcting the mechanical problem to move the respiratory muscle and to inflate the lungs, but what you're doing is you're just hiding the real problem. When a patient with Pompe disease without any infection or any other comorbidity lowers the amount of his or her oxygen, it's most likely because the amount of carbon dioxide is high and has been high for months. And the cause of this problem is mechanical, not because of gas exchange. A Pompe patient with respiratory involvement comes in, which puts the pulsometer in, because everyone has a pulsometer in CASA ever since COVID, everyone has that. You put your pulsimeter and you've got 90%. It's a mistake when you to measure that. Because the problem isn't the 89%. It's that you're going to have your carbon dioxide at 70, and when you're adding oxygen, not only are you not resolving this, you're just hiding this. And the oxygen excess, hyperoxia, leads to an increase in hydrogen dioxide increase. So it's going to worsen the situation. if there is a decrease of oxygen outside of a respiratory infection, you must consult, not to give me oxygen, but to evaluate my respiratory musculature. I agree with Anna. It's very important. I am going to focus this from another point of view, from the doctors who prescribe this. And this is a pity. It's because of not knowing enough about the disease. These are rare diseases. And when a respiratory patient comes to a primary healthcare doctor and I give a bronchodilator, a bit of oxygen to home, and the patient ends up in a coma in the hospital. I've seen this. Even in the emergency at my hospital, a neuromuscular patient comes to the hospital, and he's treated as if he were an asthmatic patient. They have him stuck in a corner with oxygen. No, he's got low oxygen saturation. Patient, little by little, the carbon dioxide goes up, and then it's very difficult to recuperate this patient. So we're going to have to remember that not all respiratory patients, they're not all the same. They should not all be treated the same. An appendicitis isn't treated the same as a cancer of the colon, and these are problems of the abdomen. So here in the respiratory tract, the same thing occurs.
Muchas gracias.
Very insightful and important information, I think, for our participants. We have a little time left, and I think if there are any questions that, okay, yeah.
They have to wait for the microphone, otherwise we can't hear the questions.
First, I'd like to say that I was lucky enough that with different patients, we went to Dr. Sancho, and he was in the Cervera hospital. And I was very lucky because I left that hospital with a volumetric ventilator. And she was saying, she was telling me what I had, but couldn't understand. But I used the BPAP and the ventilator. Are they different? Of course, the BPAP, it's to give air, but the ventilator is an electronic lung, so the lung will work. But I think there are doctors who don't know what this is all about. So I go to the hospital and I say, I want a BPAP. No, a ventilator. So I'm going to finish because but you doctors have left everything very clear. But some doctors just don't understand. In hospitals, and you go, I have to explain to a pneumologist, to a neurologist, or what have you, hey, there are other things that you can use. And they say, listen, the gasometry it's painful. They're arterial. Well, never hurt me. I guess maybe some people it hurts, so that's what we do. And then I can do it every few months, and then with this, a miracle would have to happen. This is why the only thing I've been thinking about is to tape your presentations and to show my doctor and say, hey, learn from these doctors. Learn from these doctors. In fact, BiPAP and the volumetric ventilator are both ventilators. What happens, and their function is the same, to put air in under pressure, but into the lungs. What happens is one. The BiPAP, we program pressure, and the ventilators send air until the pressure that we have programmed is reached. And so air is sent until the amount of air we've determined, regardless of the amount of pressure they need. They're both equally effective. What happens is you have to know how to handle it. If you work with BiPAP, you have to learn how to work. If you know with volumetric, you need to know how to do that well. But a patient with Pompe can either have a BiPAP or a volumetric, as long as they are adjusted correctly. Yes, that is the case. They're not using a microphone. Hello. I'm behind the column. I'm hidden back here. I was going to ask a question, but first I'd like to make a comment. What Ignacio said about gasometry. Many patients, they say, oh, and I don't want that because it hurts. And they say, oh, what about anesthesia? But what hurts more is the anesthesia than gasometry. If gasometry is done correctly, then it's like it's nothing. My question is for Ana and to all of you, actually. In respiratory physio in Spain, and it's nothing here. It depends on the interest of the patient, him or herself. So I have exercise devices and apps, and I have an app. The problem is how can we choose exercises, the right exercises, and if the exercises are considered to be used for Pompe patients. I know that people use these for sports activities, and they say respiration because you want to just force your chest cage to take in the maximum vital capacity. How can we ourselves do this? How can we get information to be able to do exercises and so it not harm our diaphragm? Thank you. Yes, of course. You just imagine if we don't have physiotherapists, how can we even have studies about that? It's unimaginable. But we must individualize, personalize the type of respiratory physiotherapy to be applied. They're not the same physios. They're not the same for an athlete who wants to get greater lung capacity, respiratory capacity, if he is a deep-sea diver, for example. So what I believe, and I know that many studies should be carried out because we don't have enough for each and every pathology, but Pompe disease, well, the lung tissue usually is not involved, so this will not be pneumothorax, which is the greatest worry of respiratory physiotherapists, because, if smokers would have emphysema, but not normal patients. But this is a progressive disease, and it causes muscle atrophy. The main objective is not to necessarily gain muscle strength. It's just not to lose it, but to conserve it, to preserve it. So it's important to do, you should monitor this physiotherapy using a parameter, whichever one you wish, and to see that muscle strength be maintained. In this sense, we can use spirometry. You can use in maximum inspiratory pressure the PIM or the SNP, but the best thing would be to monitor this every 2 or 3 months just to verify the fact that you're not losing muscle strength. The problem is not to monitor, but my problem is that I sleep with a BiPAP, and it's a hospital device. And I can do the exercises I wish, I can put the pressure I wish, and I can put it in a pen drive. I can do what I want with this. Yeah, well, be careful be careful it doesn't get blocked. Careful here. Sometimes I think it's important to know how these devices work, but the problem is that there are tools, but we really don't know how to use them correctly, and the professionals don't know either. Respiratory physio and myself, we have a reference center in Barcelona, and they do know. But rare diseases are not a priority in any reference center, in any great big hospital, in primary health care, and even in third-level hospitals. Yes, you're completely right. Well, we need a lot of training, and physiotherapy in general in Spain is in respiratory musculoskeletal. It's not so good in respiratory physio. It's practically non-existent. Many of the techniques for rehabilitation of the respiratory muscles with physiotherapy are designed depending upon the values that Ana mentioned, the inspired maximum inspiratory pressures. And to work on inspiratory muscle, you need to regulate the function of parameters that have been measured previously, and unfortunately you cannot do it in your house with a tablet or anything. We have we do not have enough respiratory physiotherapists for them to design your own personalized program, because what is good for one patient isn't necessarily good for the next. In my case, in 8 years, my physio did just moving my muscles. I certainly don't think that's enough. The incentivator, the 3 little balls, yeah, that's not enough blowing. I do the same thing. I blow on those little balls. So the 3 balls, little balls, and you blow, you have to, yeah, but you always have the same resistance. So you can just prolong the inspiration time, but the inspiratory isn't the same as the pressure. So these 3 little balls, and the traditional use was to avoid atelectasis. And so for muscle training, this is it's not good enough. And the AeroFit application that was mentioned by the Public Healthcare Services, Ifrit, what do you think? No. It's AeroFit. I have nothing to say about that. It's a pity. Anna was mentioning this because they're physiotherapists, and you need to get a very high grade to get into the universities to study physiotherapy, but very few people are even interested in respiratory physiotherapy. The rest just get a bag of what? Well, they say, blow here, put the hand on your abdomen and see how you breathe. This is completely useless. There's a whole world out there, and in Spain we're in prehistory. Unfortunately, we are in the prehistory along with this, and there's really not much we can do. Maybe if you have someone can help you get into the National Healthcare Service, and you have an in there, who knows? Well, this has to do with pneumology. If with an intervention, and we're going to undergo general anesthesia or a test, the same thing happens. The anesthetist, I tell my anesthetist, because I'm afraid if I have to have an operation, what should we be particularly careful with? For example, I had a colonoscopy not long ago, and I took my BiPAP, and I said, "Are you going to need? Will I need my BiPAP?" I went with my little device because I didn't know, but they don't know anything, and if they don't know anything, they'd really. Well, anyway, this happens everywhere, all around the world. This is a struggle we know ventilation pneumologists to domicile have constantly. People with respiratory problems, and you use your BiPAP at night if you're going to be sedated, this will also have to be used. It is some anesthesiologists prefer not to use it up front, but they are monitoring you, so while the operation is in course, they're monitoring you. But as soon as your saturator or your carbon dioxide goes up, they're going to have your BiPAP to be able to check. But the patient should always take his or her device along. So we recommend with any type of sedation, adapt the BiPAP, which is your own. The patient puts it on himself. I put it on by myself. I turn it on, and that's it. But it's facts. The fact that almost all anesthesiologists prefer to start their procedure, and if there are any complications, then we'll put the BiPAP on. But usually this goes along with a call to the pneumologist, because they say, "How do you turn this on?" Well, the patient knows how. Well, he's sedated, so he should have turned it on before. But always, you've got to take it with you for any hospital admission or an urgency. You don't know if you're going to be in the hospitalized or for any scheduled operation. Before your scheduled operation, consult with your usual pneumologist so that he will verify that the pressure of the respiratory are good, that there's no important leak, that everything is just fine and dandy. Hello, good afternoon. First and foremost, I'd like to thank you ever so much for your presentation, and thank you to the association, because I've been coming for some years now, and I have learned so much today and other years. I think that we focus so much on respiratory involvement. And I think that we haven't in the past looked at this much, but now more so. It's very interesting. And Barbara, I've known you for some time now, and my daughter is asymptomatic, but it's true that many doubts and misgivings come up after listening to you all today. Maybe you've already said it, but I'd like to be clear about this. The first thing is we mainly go to the neurologist and in La Paz Hospital, and sometimes he does spirometry and a little bit and not much more. And from the motor point and functional point of view, everything is fine, but at nighttime he coughs and wakes up coughing. And so, and his mother and I ask ourselves if this might be a first symptom that we should keep watch over, and if this might be that the diaphragm, it's just one of the involved muscles, it might be the one that might firstly show these symptoms. That's very rare. The respiratory debut in Pompe disease is rare. Almost all the patients with this respiratory problem, it's very odd and rare for it to begin with the diaphragm, although cases have been described.
What's the age of your daughter? Well, there are not so much mucus at school, so that to be coughing at night. In the next consultation with the doctor, the children per protocol should have polysomnography done to detect respiratory involvement. And the study should be done not at home, but in the hospital with EEG monitoring as well. One of the doubts we had, because in the last sessions, a couple of spirometries when she had some mucus, they were doubts if she could be asthmatic or not. She had also a certain allergy, as everyone, to graminosaceae and to grass, and they had doubts about that interference. Could one confound the onset of symptoms with being asthmatic? No, never. No way. Well, if a pneumologist, supposedly serious that in La Paz in Madrid, says that they shouldn't normally are not wrong, but you mentioned that she wakes up at night, etc. Well, this doesn't happen, but it was in a given period of time. Maybe this coincided with allergy issues due to the season of the year. It was last year. The symptoms of asthma have nothing to do with the symptoms of hyperventilation nor sleep disorders either. You can't confound them. Asthma has nothing to do with waking up at night. If she wakes up at night coughing, and yes, this could be, but this is not repeated. It's very occasional. They don't persist in time with wheezing or from asthma. With the suspicion of the Pompe diagnosis, you can't play with that. You have to make the sleep study. Another thing that is not too clear to me either yet, the level of functionality of the diaphragm. Is it evolutive? We have never had a diaphragmatic MRI, but can they see if the diaphragm is involved, or is that an evolution? From the first ultrasound, you can see if there is a diaphragmatic evolution in a very clear-cut manner, by the way. Thank you. I wanted to ask the test that you are talking about, how often is it done? How my child does also cough. He wakes up coughing. He drinks water, and that helps him. He is also asymptomatic. And I wanted to know if the test that you have mentioned, how often is the sleep test, the polysomnography. Normally, if the polysomnography is strictly normal, we can do that every 1 or 2 years. And apart from that, if we have any suspicion whether there is a symptom that may suggest that she can have respiratory problems, then I do that as well. You are not playing around with it. You do it whenever you have the suspicion. It can be accompanied by headache, and headache, in fact, makes you do the test even earlier, because the child, if he has headache, until now we were thinking that it was a contraindication normally of the treatment or something of that sort, or of his own, that he was nervous. So the test has to be done. There are tests that you think about doing them or not. A lumbar puncture, but an invasive test, there are too much risk benefits, sedate the child, etc. But a sleep test, you have to do that. You do it and that's it. Because it's very easy to rule out any problem, and it gives you a lot of information, prognostic, from the prognosis, follow-up, etc. And can it have something to do with the movement, the eye movement as well? The eye movement are part of the sleep phases. There is a phase of slow eye movement and one of rapid eye movement, and this can be normal. The rapid eye movements, this is physiological, this is normal. But it's not normal that they don't sleep well and that he has headache in the morning. You have to see that. It can also be at midday as well when he complains about headache. You have to look at it, yes. Thank you.
I do think we need to stop here. Thank you so much. We had a wonderful conversation with you, and we'll be happy to continue on break, but we do need to move on. Thank you.
Espera.
¿Me oís bien, no? Sí. Uno de los objetivos de contar con un registro de pacientes.
One of the we have of doing records of patients with Pompe disease is to have data for the neuromuscular disease and rare diseases. A registry in which, from the Association of Pompe patients and with collaboration of the medical experts and of course of the people who are involved in the family as well, we are working on. And we have now data that we will know today. The survey that we gave to all the members a few months ago is helping us to keep on knowing and going to more in depth in the disease. Data that you're going to know from Dr. Genaro Martín from the Hospital La Paz in Madrid, whom we invited us to be here with us. Let's hope I can find it.
Hola, bueno.
Hello. I hope that I can give some interesting data. It's quite simple with my talk, introduction to the disease that is not going to be new for anyone. We are going to talk about the registry, what we have seen, and four things that can be interesting as well. And then finally, I will talk about the survey that I had to analyze, and I can give some conclusions with it. I would like to, well, this is more than what I can tell you now. We talk about the Pompe disease. It's given to a deficit of acid alpha-glucosidase, mutation in the gene GAA, and it is known as glucogenosis type 2. The glucogen is accumulated in the abnormal form in the cells, producing inactivation of the lysosomes, and this entails an accumulation and a progressive deterioration of many types of cells, but mainly of the muscle cells. Classically so, they are two forms, the classical children's child Pompe under the age of 12 months with hepatomegaly and as a definitive form, and then we have the late adult form, although it's not so adult and not so late either. Very often the child that at 1 year has this onset we consider that as a late onset already. That is the non-classical infantile form. It has a more muscular profile. And we have to understand that until a while ago, there were no data that talked about the epidemiology of the disease at the level of in our country. And that's why we tried to form this registry, the Spanish registry of Pompe's disease. And it's a registry that is hospital-centered, in which the actors are the physicians in the units of the degenerative diseases, muscle diseases, in all the whole geography in Spain. They collaborate with us and they receive the data of the patients and analyze them and accumulating them in order to have viable data from the patients. The coordinator of the registry person was created. In this case, it's myself. We communicate with the different places, introduce the data, and also spread the data, manage the data, and publish the data as well. We have two ways of accessing the physicians. One is telematic, and the other is personal. I have a picture with people. Some of you are here with me as well, and we see different in different places. But now we're not going to talk about that. We are in many hospitals, nearly 30 have collaborated throughout the geography. I'm not going to talk about them anymore, but I would like to mention.
Because I'd like to speak about some data that we have. We have 130 patients who've been recruited to the moment, and the average age appears up here. And you can see the results here. Look, that's because this is a bit asymmetric. And then there are two types of disease here. In Spain, we can see there are different registries. And above all, we see the adult type. And in red, you see children. This is young children. And it's interesting to notice, in our particular case, and look at here, the late onset patients. Well, we have the most common mutation, and we have information from 100 symptomatic patients. And this is difficult for me to tell you about this, but I think that we can speak a bit more about this. But respiratory failure is quite important. And we've already have 40 patients in our cohort who receive some type of ventilation, support ventilation, that is. I'd like to tell you about two interesting things. These are interesting symptoms in the adult patients. I want to underline respiratory failure. And as our colleagues said beforehand, we have symptoms, and this is very important. We know there's a weakness in different muscles, and with children, I'd like to say one interesting thing. In our registry, the fact is that one of the first symptoms that we see is the cardiomyopathy. This is always an important symptom. We see it in children, but it's what appears most early on. And then we always see this in our therapies. A few more words concerning the epidemiology. And here, we don't have the 130 patients up here, but when we speak about, we have Andalusia, Catalonia, and it seems that Catalonia shows, we can see this up here, but then when we see in Andalusia, it seems that most of the parents were born in Andalusia. Well, the children were born in Andalusia, and then they immigrated. And so this contrasts with the fact that others were born in other autonomous communities. But it's curious that most of them come from the south. There's more of mutations that from in the south and predominantly in Cordoba. And this is a patient survey, and this is a survey that we did in July, and I think some patients, most of them filled this out, but we have data from 50 patients who answered these questions, average age, about 40 years old. And curiously, the parity was quite well between genders 25 to 25. And most of these people belonged to an association. Thanks to the registry, we were able to learn more. And quite a few had other pathologies as well. I'd say about a quarter of these people had other pathologies, and 88% received treatment, and 8% were confined to their own homes. And treatment, the time that the treatment had gone on was about. We saw this in about 9%, 9 of these patients. And in neurology, and this is something that we look at. And one thing we look at is the loss of grip strength, for example. And I'd like to mention the same as in other information that came from our registry. The people who answer our surveys came from Andalusia because it seems that there are more patients who were born in Andalusia. And other symptoms, it's true that there's nothing new under the sun. And it seems that when we interviewed these patients, almost all had weakness in their lower limbs, mostly the lower limbs, more so than the upper limbs. And there's the neurologist sometimes don't usually look at the pain. More than half the patients felt and had chronic pain or pain of some kind. And in the interview, they would say, well, sometimes they felt quite a lot of pain. But they always spoke about myalgias and type of pain in their muscles. What struck me as a neurologist, I was wanting to ask my patients about pain. So something else I think is interesting is that 1/3 of the patients who were interviewed were not in agreement with the moment or the time that they were treated and their diagnosis. So they say when they think that they were diagnosed right up front, but sometimes the patients felt these symptoms before they were even diagnosed. Well, it's a fact that many of these patients have important disabilities, and some have an absolute disability. Something else that is interesting and which struck me was the survey at 6.1 years. Well, it's curious that there was another registry that lasted 11 years. Maybe each registry was handled in a different manner. Maybe there is some type of problem, and some people have an earlier or a later diagnosis, and some patients say that they have been diagnosed, but they still don't have symptoms according to the registry. Well, the fact is that there is a change, and that refers to 5 years. Maybe, well, obviously some were diagnosed earlier than others, according to the registry. Well, almost 40% of the patients were diagnosed 10 years before. Maybe it was even more so, and maybe things are changing now as more people are informed. But something that struck me, and it's not a scientific truth, but when we look at the dispersion in these diagnoses, there was a certain tendency because the later the diagnosis, the greater is the disability that the patient will present in the end. There's something else that struck me when we speak about the symptoms and what the patient tells you that what he or she needs of some type of support. 1/4 of the patients need a cane, others need a walker, more than half need a wheelchair for their daily lives. But there's a very small percentage, and it's this one, that just need these special splints for so they won't have foot drop. This struck me quite a bit because some people have feet like this, and here, and I asked this person to lift his feet, and this like it, you call it equine feet. And these are patients who've been treated from a very early age, and they have a distal weakness, more so than a proximal problem. This is just an anecdote, but this is something that struck me definitely because it's difficult to notice in a registry of a lot of patients. But if you have a sample of just 50 patients, when you ask these questions, you can get interesting little bits of information. I think it's quite striking. And of the 50 who responded, we asked what their follow-up was like. 42 if they had stress tests, and 41 respiratory tests, and 13 muscle tests. And I wanted to show you this graph. And in red and in blue, well, blue means stress test, and green MRI. This is different. Some have a stress test, some force or strength and respiratory tests, and some did not even respond, and some the three. I don't know why, but this does show that the follow-up is different from center to center. Maybe there's something deeper behind all of this, but I just wanted to show you all of this because this is an interesting finding. Lastly, or next to the last actually, I wanted to show you something and support. And 50% received some type of support and physiotherapy, but there's an error on this slide, but just 2 had physiotherapy that they did not pay for. That was funded by the association, but the rest, they had no type of aid. Lastly, quality of life. We're looking at this now in our studies and in science, and this is something that we want to ask, that we ask the patient about his or her quality of life. And so, well, general health, ability to perform physical activities and mental health. There are patients who say so-so or bad, and this is in green. And purple. Purple shows, well, this is a chronic pathology. And so, to conclude, I'd like to mention that Pompe disease it's infrequent, but it's with it, but it has a real dependency burden. And the National Registry comes from true information about the number, the follow-up, and the number of patients with the disease. And we can look at new aspects of this disease, and we can think about things that haven't been reported previously. I think that this survey gives us important information, because up to the moment these things were not even considered. The patient was in the center, and lastly, I would like to say that the care is not always fair. It's not always equal, and there should be a consensus here. There is one, but we should make this more obvious regarding the follow-up of these patients. And without further ado, I will. This is the registry that I wanted to tell you about. Thank you very much.
Le entregamos un obsequio.
Well, I would like to give you a gift on behalf of the association. I wanted to ask a question first. This is more concerning the data you presented. It's something that is important, in my opinion, to point out. The diagnosis in the sample of 6 years is that the association, Pompe Association, is a very recent association from 2017, and the sampling of persons is not the real sample of all the Pompe patients. There are many people who have not, whom we haven't reached, that are those that we have started the treatment initially now. 11 is even too little, but it was only that assessment of the data that you have given us. It is true that when we calculated that, it's certain that it's true that when we have to match, so to speak, the patients who already have a prior diagnosis, prior to the symptomatology, it's more difficult to quantify how much is that, because in theory we are diagnosing before the clinical picture setting. Sometimes it's hard to say how much is really the diagnosis. We have to say, how we think about it as something negative. It's not so easy to do that. Microphone, please. Contribution. I'm going. Javier Fernandez Salido, the father of Lucas, who was the patient who received it for the first time. The therapy in Spain. He was a scholar of everything that had to do with Pompe's disease. The establishments, from Caroline and all this area that we. I don't know if it was Carlos II or the King Charles II, and many people from Holland did also go there. If you study the amount of patients that exist, I don't know now what's the term, says the speaker, per patient, per person is in Holland very high. It's very well studied, and they have been studying for many years. But he maintained that thesis, and when the 26 have come up, well, we Andalusians, we gave something to Spain. And then we go to Barcelona, we have to distribute everything. And when I tell that, and in some congress and meeting, they say, doesn't have to do with Maghreb in Africa. Well, I don't think so, I don't know. Not all patients who come from, it seems there are no Jews there. Well,
¿Hay estudios o se recoge alguna?
There are studies. Do they collect that this information of more cases is due to consanguinity relatives, close relatives who have married each other, and the parents are related, consanguinity? I have different, the haplotypes are different from the variables one, but most of the people with Pompe disease are two different variables. that are necessary to have two variables to diffuse the disease. There are some that have the same variable both, but it is true that most of them are different. So when we study the variable of father and the mother, most of the times they are different. So casually, we all are carriers of some disease, but when we have children, normally, due to mere statistics, they don't inherit the disease as such. But sometimes this type of problems happen, and they are a carrier of a bad variable. They produce the disease in the child. In our study, it's very infrequent, at least this intermarriage, this consanguinity, if we look at the variable alone.
A continuación.
And now, now we are going to approach one of the issues that has the greatest incidence and interest for the patients who have Pompe disease. The clinical updates, the update of the clinical management, late Pompe and childhood Pompe. We will talk about that with a strong conviction that the clinical and therapeutic decisions for the patients with Pompe should be taken in the setting of multidisciplinary boards that include all the specialties involved in the management of this disease. An update of the clinical management that will always have as the basis the research in order to approach that topic. We welcome Dr. Nuria Muelas from the University Hospital, Polytechnic from Valencia.
Moderadora de la mesa redonda.
The moderator and the participation of Dr. Cristina Dominguez from the 12th of October Teaching Hospital in Madrid. And Dr. Javier de las Heras from the Cruces de Vizcaya University Hospital. Good afternoon, one and all. It's a pleasure to be here with patients, relatives, and other professionals involved in the care of patients who have Pompe disease. I am Nuria Muelas from the La Fe University Hospital. I am a local here, and it's a pleasure to have on my left-hand side other colleagues from Spain who are going to introduce themselves and later will talk. Good afternoon. Thank you to the organizers for having invited me one more year to participate in this panel session. I'm Cristina Dominguez, and I work in the 12th of October Hospital in Madrid with Dr. Ana Hernandez, who is next to me, and I'm delighted to be here. Good afternoon, one and all. Thank you so much for inviting me to be here. It's a real pleasure. I see people I know out there. I'm Javier de las Heras. I'm a pediatrician, and I work in the Cruces Hospital in Bilbao. I work with hereditary metabolic diseases, and lately I am getting experience with Pompe disease. And the fact is, it's a pleasure to be here with all of you this afternoon. Very well, we have organized this panel session, and we are going to show a few slides. Each one of us will focus on certain aspects. I'm going to speak about general aspects tied into research, general research, that is, because the later sessions will speak in detail about gene therapy, new enzyme therapies, and the like. And Cristina Dominguez, who is a neurologist, basically an adult patient, she is going to explain what research is going on in the adult Pompe patient. And Javier de las Heras will focus more on the infantile and pediatric aspects. We're going to do a bit of gymnastics here, going from one end to the other. Let me look for my presentation.
Un placer estar aquí y espero que
It's a pleasure to be here, and I hope that there are more patients are seeing us at home virtually, and I hope that we can contribute to a better understanding of aspects which might seem to be a bit basic, but at the moment everyone wants to participate in clinical trials, and so we need to know what we're coping with when we're speaking about research and in clinical trials. The first thing we need to bear in mind is what is a clinical trial. It's a research study in human beings which looks at the efficacy of drugs. And clinical trials are developed by following experimental protocols, and they're highly defined, and to see which patients will be recruited, which will not be included, and what will be performed in these patients. For a clinical trial, many years previously, there's a preclinical phase, above all with these medications. As I say, preclinical phase. This usually starts with research animals, firstly with cells from the patients who do have the disease, and they donate their cells for research. These preclinical phases will last, well, quite a few years, an average 3 or 4 years. And this is important to define action mechanism, for example, of the medication, of the drug, what will curb or to cure, that would be the ideal thing, the disease, and what mechanisms are there for toxicity or side effects, undesirable side effects, and what could occur with our patients. Depending upon this, well, one will decide if these molecules will be viable or not. On the right-hand side, you can see that there are thousands and thousands of compounds that are under development. This is a funnel. Look at how it's getting smaller and smaller. In the preclinical phases, we see what happens in the end. And the clinical trial, you see that the proportion is even smaller yet. So with the commercialization, then we see what happens. So in the clinical trial phase, once we've had the preclinical phase, the first thing is we do have a research phase, and we have phase 1. Well, they're healthy individuals who voluntarily say that they will test these therapies, and we will see if there's a side effect or action mechanisms, and the behavior and the distribution of those medications. Where we do labs, we study the pharmacokinetics of the drugs. And if phase 1 is suitable, it's when the drug will pass to phase 2 in the research. Here, the drug will be tested on patients who do have the disease. Phase 2 studies are studies which recruit very few patients, in fact. These are very reduced in size, these studies are. And we will see dose stratification to see the most adequate, most suitable dose to apply this to the disease. These are complex. They're done with very few patients and also in not too many centers. So we look at the dose aspect and side effects and tolerability, and we see if there's efficacy for the patients. Then in phase 3, once we've seen that phase 2, the drug is safe and it has a positive effect on the disease, this is when we shall begin phase 3 of the clinical trial, which will recruit a more important number of patients. Depending upon the disease, it will be numerous or not. And this concentrates patients from different countries all around the world. And this represents different races and ethnic groups to see if the drug is efficient in different individuals. And here we're going to test one single dose. And this, we've looked at this in phase 2 already, but here we're going to, above all, see more solid data considering efficacy. We're always going to be looking at the tolerability and also side effects. And in the end, a very small number of these drugs will go on to phase 4. This is a phase until the drug is marketed in a formal fashion and could be used to treat the disease. With all of this, we often want to know what is there for our disease and how we can find trials, research, activities to be part of this. Here on this slide, I put down the 3 different important resources to see what is being done in clinical resources. We have the Spanish Registry of Clinical Trials. Then we have one comes from the European Drug Agency and one for the United States, which is the Clinical Trials Gov. And here you write in the number of the disease, the types of trials that are being done for this particular disease. And here we must bear in mind that not only do we research in drugs or potential therapies, but also there are observational studies and studies of natural history, which are also very important for these diseases. And sometimes we don't know too much, but we're always learning continuously. On the right-hand side, I've put down a study of the natural history of infantile onset Pompe disease, and the therapies conclude that this is a potentially lethal disease. And so we are learning more things from these studies of the natural history of the disease, and also the importance about the registries, patient registries. And here we'll know how many patients we have in our country, their characteristics, and we can even locate patients in order to be able to apply these types of interventions or trials. And so here the clinical trials are complex. I'm a neurologist, a clinical neurologist, but I also do research and I participate in clinical trials. I have been for quite a few years now. We began in 2008, 2009. This is when we began doing research in neuromuscular studies, and we participated in the first clinical trial with a drug for Duchenne's disease. And so I've seen the development of these trials and how more and more each day things are evolving in these clinical trials. And since there are more complexities, the trial must focus on the patient, and the associations play a fundamental role here, a very essential role. Here we have specialized centers aware of these diseases, and they are able to recruit these kinds of patients. Sometimes these are rare diseases or ultra-rare diseases, with teams of professionals who come from many different areas. Not only do we have doctors and nurses, but also we're going to have physiotherapists, lab technicians, people from pharmacies, and we have to have research institutes. And economically speaking, this is a lot of money involved here, and so there needs to be a participation not only of foreign companies or private companies, but also there are other studies that get funding. They have their own funding or governmental funding, or the associations also help fund these studies. So here we're seeing the complexity behind a trial. We have the evaluations and the functional tests, which are done very selectively to be able to see these changes in the disease. Each neuromuscular disease is going to have handicaps and more specific types of tests, and also drug delivery, very complex, because we're talking about gene therapy and Duchenne and Pompe as well, and how these drugs are delivered or administered. Well, this is highly complex. We have to have very sterile conditions, very specific conditions, and later we need to obtain, process, send samples, not only blood, but we do get a muscle biopsy and send that in to see if that drug, if that intervention has a positive effect on the muscle. This is our target organ. And then we do use MRI. This is a very easy test, and it gives a lot of information in neuromuscular diseases. With all of this, I would just like to conclude by saying that it's important to see how important research is, and these clinical trials are. Actually, not only using drugs and looking at other aspects of these diseases, all of these are so necessary to move forward in the treatment of our patients and to learn more. It's very important to cooperate and participate with patients, with associations, and with family members. We need to have specialist centers who know how to handle these neuromuscular diseases and clinical trials. And because, as I've said, we have people from different professional backgrounds to back up this research project, even though the research, and we're all so passionate about this, but let us not forget how important it is to use the standards of care of these disease or other neuromuscular disease, and this must all be done very suitably, adequately, and in a multidisciplinary fashion. Economically speaking, the investment required for all of this, well, these funds, if only they could flow more generously from the nonprofit part, from public entities and or associations and the industry. And with this, I conclude. And here we see our research group from LaPe University Hospital with all our colleagues. Nothing more, and thank you so much. I'll now give the floor to my colleagues.
Muchas gracias.
Thank you, Nuria. As we've said, I see exclusively adult patients. And the idea in this brief presentation was to review some of the news, the novelties in the last year as to basic research and clinical research is concerned. I have reviewed the papers that have been published this year in 2023, and I have selected 5 of them that I know the conclusions of which can be practical for your daily life. I'm going to summarize them rapidly. I'm going to focus on the conclusion of each one of these papers. The first that I chose talks about physical activity, because you know that there have been many studies that have been made, always with few patients, always very short studies. So it's not yet too well proven, but there is more and more evidence that adds that the physical activity on a regular basis in all patients with Pompe disease, adapted each one to their possibilities, improved their physical condition. In that paper, the Dutch group makes a study in a series of patients that they have been followed for more than 10 years. And what they do is analyze if those patients who achieve physical activity on a regular basis, when 10 years have elapsed, and they are under better conditions than those who were similar to start with those patients, but they led a different life, a more sedentary life, still life. But we regular physical activity is considered, and healthy activity are the recommendations given by the WHO that are recently updated, but I followed those in 2010. At least 150 minutes of aerobic moderate exercise per week. Moderate exercise is to walk fast or in bicycle. Or on the other hand, 75 minutes per week of a very vigorous physical exercise. And this, for instance, is running. They say that apart from this physical activity, we have to add twice a week of strength training as well. This is what is recommended in order to have a healthy physical activity. What they review in this group, after 10 years, those who really have had that physical activity in a regular manner, compared with those who had a sedentary life, were clearly better in all the items analyzed, both in physical endurance and strength and the functional capacity. That means that the conclusion, once again, after this new study, is that, in fact, we have to try to promote physical activity, adapt it for each one to what they can do, but in patients with Pompe disease, that can be generalized to all the neuromuscular disease. It's essential to try to maintain as active a possible life as possible, because this has a direct translation into the muscle to be preserved as best as possible. In this other paper, from the Dutch group as well, what they want to analyze is the treatment of the home treatment, the safety of the home treatment. We know that when it was authorized for the first time, the Myozyme, it was done with the alert that it should be given in a hospital due to the risk of allergic reactions. In the Dutch group, they started very soon to make this treatment at home. And in this study, what they do is analyzing after 18,380 infusions throughout those years, the safety results. They established a protocol in which the patient, first of all, the first year of treatment, he does it in the hospital to be certain that he has no adverse reactions, and then a series of nurses that are trained, that know how to recognize if there is an adverse reaction and treat it as well, and that have a medical support team in the hospital that is on duty. With that protocol, they have done from 2008, I think, home treatments, home-based treatments. In this analysis that you can see, what were the reactions after 18,300 infusions, 121 adult patients. They see that the existence of reactions to the drug is very low. In the hospital, it only happens in 3% of the infusions, and in the home-based, in less than 1% is there any type of reaction. And that the reaction that happens, most of it are mild reactions. When in the hospital, 80% are mild, and at home, 92% are mild reactions. A little fever, discomfort, and that type of reaction, stopping the infusion of the drug and then restarting it at a slower pace, they go over. They disappear. But they only observed 4 severe reactions in the hospital out of 20,000 infusions, and 1 at home that required care in the hospital. Those severe reactions that are allergic reactions are solved with the intravenous treatment of corticoids and antihistaminic drugs. The conclusion with this study is that the home-based treatment, in this case with myozyme, but also with the new enzymes as well, is safe, always following a very strict protocol and starting the treatments first in the hospital. This third paper is a systematic review that wants to tell that they analyze the results of many different publications, and they focus on knowing if the antibodies generated against the drug have an influence on the effect of the treatment itself. We know that the infantile forms, especially the most severe ones in which they don't have their own protein, there are immune reactions that are very intense that require specific treatment and that do have an influence on the benefit given by the treatment. But in the population of patients with a late onset, where we know that all of them will develop antibodies to the treatment, it's controversial still yet if those antibodies developed really prevent the drug to work properly. And they analyzed 17 different publications, analyzing a total of 443 cases. And they conclude that although the antibodies are produced in all patients, the titer of antibodies, the amount of antibodies generated in the majority of cases is low, or is low enough in order not for them to generate any type of problem. When very high antibody generation takes place, nobody knows what's the limit to talk about very, very high antibodies. In some papers, they talk about 1 out of 12,000 or 1 out of 50,000. We know when there are many, many antibodies, but those figures are very infrequent. They happen in an exceptional manner. We know that even in those patients with antibodies that are so high, the immense majority of them are not going to have any effect on the benefit caused by the treatment, because although they are somehow neutralizing the effect when it's analyzed in vitro, what we have seen in those cases that at patient reality there is no change in the clinical benefit he obtained with the drug. So even the few cases that had very, very high antibodies, it doesn't seem this has an influence on the benefit of the medication. We have seen also as well that those patients who develop antibodies or more antibodies generally are the same that have some adverse reactions when the medication is introduced. Maybe these are patients who need a pre-medication when the drug is given. But very important, they are not interfering with the benefit of the medication. This paper of basic research seemed very relevant to me, especially in view of the new enzymes. Jorge will talk about the new treatments, and one of the new enzymes that will be tested is a combined treatment using the enzyme acid alpha-glucosidase in combination with an oral therapy that is an enzyme stabilizer. In this paper that is funded by Sanofi, what they try to show is that this stabilizer that is taken orally could also improve the activity of these 2 other enzymes on the market, myozyme and the new that will start, the Biazyme, that is a new enzyme from Sanofi. The enzyme from Sanofi doesn't have a stabilizer orally. The one that has a stabilizer is the other treatment. What they want to verify is that if that oral stabilizer is also able to improve the activity of those other enzymes. It seemed interesting to me because we can think if such a drug exists that I take orally and that makes the enzyme work better, why don't take it, although I'm using myozyme or the new one? And what was What they show is that they analyze both in vitro and in animal models, in mouse model, and they show that nor in myozyme nor aval glucosidase, that is the new one, adding miglustat, that is the stabilizer, oral stabilizer, makes the enzyme work better. The enzyme is working equally well with the stabilizers than without it. So it wouldn't be necessary to add any oral drug to those two enzymes because this doesn't contribute with anything. But what we show in this paper is that comparing the new drug with aval glucosidase with myozyme is aval glucosidase is more potent when degrading the glycogen from the tissues. It had been proven already, and this is pointed out in this paper. The oral stabilizers would be indicated only for that other enzyme, aval glucosidase, that is the one that requires the stabilizer to act. And this is the last paper. Just calling on your attention, you all have heard about ChatGPT. It's a chatbot with which you can chat. You have to know that in this type of chats, the content that it's returning to you when you are maintaining a conversation doesn't need to be truthful. It can be invented. You can ask about the disease and it can return you a content that in reality is not real. This is important for you to know because you can think about, well, I have here a chat with which I can chat that is connected to the internet. I'm going to ask about the problems of my disease, the treatments. You can receive in return invented information. I found this paper where many scientists using this tool in order to write the scientific papers more rapidly because it returns rapidly a text. And in reality, we have to know that it can give back to you a text that is false. So in this paper, they were asking about the Pompe's late onset Pompe disease. And they asked, describe the late onset Pompe disease and the liver involvement. And what the ChatGPT answered said that a Pompe disease of late onset, there was a very important liver problem with a hepatomegaly that could lead to severe and progressive problems and hemorrhagic secondary disorders. So it has invented from nowhere a complication in this disease that in reality doesn't exist. You should know that in order not to use this type of tools as the physician that can use it for it's more accessible for him. All the papers that I had reviewed. Thank you very much.
Pues ahora Javier nos pondrá.
And now Javier is going to update us on the infantile onset Pompe disease.
Ya lo he visto, sí, eso lo he mirado. Pero lo de
Bueno, no sé si se me oye con este micro. ¿Sí? Vale, bueno, pues yo...
I'm a pediatrician, and I'm going to speak about Pompe disease, actually infantile onset, obviously, and I'm going to focus on the classic kind of this IOPD, the early onset. And I think that this is not represented so much because it's more rare and much more infrequent. Let us begin with a bit of theory. I think you already know about this, but Pompe disease, this is lysosome deposit where the substance which is accumulated in the lysosomes, you know that they're in the cell and glycogen is accumulated. And this is type 2, glucogenesis type 2. There is an accumulation of lysosomes in the cells, in the tissue, and then it causes the symptoms of this disease. And where does this glycogen, where does it deposit itself? In the muscle cells and in the skeletal muscle. This is the infantile onset type, IOPD. There are two different types in the clinical type. We have the infantile onset, IOPD in English, and we have the late onset PD, LOPD, the initials in English, of course. And the IOPD is the most severe kind, where generally speaking, there is a complete absence of that enzyme. Children have very, very, very few of that enzyme are not at all. And so they have to be treated very early on. Late onset may be diagnosed, for example, depending on when the symptoms begin, or if they're diagnosed pre-symptomatically, or when they're in their childhood or in adulthood. And so I'm going to focus on the IOPD, the clinic and the symptoms in a very just a baby. They have a very severe hypertrophic cardiomyopathy. The heart walls are very thickened, and weeks later, if nothing is done and they're not diagnosed, well, the child will begin with hypotony, with motor muscle problems, and with everything that we already are familiar with. So for the diagnosis, in absence here, if it hasn't in the prenatal screening, then we would have to suspect something, and so the test, the HEAL test, is done to newborns, where they rule out a series of diseases that have characteristics that if you find them very early on and they are treated very early on, this will certainly change the prognosis very importantly. And then this type of IOPD, from my point of view, would be a clear candidate. But in absence of this, if the earlier the better to diagnose this. But if we suspect this, and we doctors have to even know about this to be able to suspect it, then after that we do the genetic testing, and with enzymes, then it's very easy. So in the infantile type, it's very, very, very important to have a very early diagnosis. The minute you suspect this, you must immediately diagnose this, because if we begin earlier, better earlier than later, then if it's earlier, then the child will certainly have a change in his or her prognosis. He'll end up or not in a wheelchair, can live a normal life without a tracheotomy and so forth. This will all depend upon the early diagnosis. And when we begin, the earlier we begin the treatment, the better. So we certainly have our enzyme therapy, our enzyme replacement therapy. And here, the harm to the skeletal muscle is irreversible. It's arms, and it's the heart. The heart muscle responds very well to the treatment, but the skeletal muscle does not, and the harm is irreversible to the skeletal muscle. So one should begin before there is a motor involvement. So in the IOPD kind, the severe of the newborn baby, we must begin immediately, because days and weeks can influence the prognosis. But the LOPD, the late onset kind, this should be treated when the first symptoms appear of the disease. But here it's very important that they be followed in a very specific place where they know what they're looking for, because you're going to have to look with a very, very, very carefully to be able to find this early on. You're going to need a magnifying glass for this. And clinical case. And so why am I showing you a clinical case if we're not doctors? But I'm just going to reach some conclusions and give you some ideas about this particular clinical case. This is a baby, 2 months old, who seemed just fine. It came to the 2 months revision of the baby. The baby had not gained any weight with regards to the previous, checkup after 1 month, and besides, the breastfeeding is causing a problem. It wasn't hypotonic, and the baby could suck the milk. The problem was the fact that the mother needed to get take the breast out and then put it in a bottle, and the parents and the grandparents gave the baby. They put a little urine bag, and it seemed that there was a urine infection. So the baby was sent to the emergency ward, but just to see if the baby could breastfeed or not. But only that. And normal little girl, normal weight when she was born, nothing, no hypotony, tone, attitude perfectly normal. But in the hospital, the pediatrician did a good examination, and in the pediatrician's exam, and then it seemed that there was a slight murmur, just a very slight murmur, 1/6. So since we were in the hospital, we went to the cardiologist, and he did an electrocardiogram. You will not understand what this is. I'm not a specialist here either, but this is a heart. And it should be like this, like 4 or 5 times broader here. Seems that the walls of this heart are very thickened. And so this is very characteristic of this disease. So when one sees this, one should suspect this disease immediately. If you can see here, in this particular case, the diagnosis was reached before the patient had hypotony and the early treatment was begun. Luck, just by chance. This was just by chance because the child was admitted to the hospital. Due to another reason, a little murmur was heard, and the test was done, and that child had not gone, and the baby would have begun at 6 months with hypotony. Then the history would have been completely different for sure. So there were labs. They could see CK was high, transaminases. Look at the result. Well, Pompe disease. So now I'm going to show you the research. We check things, and then in the end, we see what happens when we write articles about our research, and so then all these articles help us reach our decisions in our hospitals, and because we don't want to do things just, well, I think this is the way it should be, and I'll do it like that. But no, we have to do things based on objectivity and very rigorously and academically, and so we should always base ourselves on the latest evidence, and so this means we have to look for information very rigorously. We have to look for scientific information and research information. 2-month-old child with Pompe disease, what do we do? Well, we're going to have to look and see what science tells us to do. So the first thing science tells us to do is we're going to have to hurry. Going to have to begin this enzyme therapy. The sooner the better. If you begin at 3 months, it might be too late. But so the earlier the better for our enzyme replacement therapy. What do the guidelines tell us? We do need to have guidelines from experts. It should be evidence-based guidelines. And so I don't know. This was in 2020. There were no updated guidelines. The latest guidelines came from 2016, 2017. And what do the guidelines tell us? They tell us that we need to immune suppress in patients who are CRIM negative in order to avoid the appearance of antibodies against the drug. What does this mean? Well, antibodies, I don't know if you know what an antibody is. When something strange comes in the body defends itself and creates antibodies against it and attacks it. It's something new. It's a foreign body that came into your body, and the leukocytes make antibodies against it to attack it. So if a patient has such a severe form and has absolutely no enzyme at all, when you're going to put the enzyme therapy in, it might recognize this as something foreign, and so then it will react against it. So in this disease, and in fact this does happen, so it means that the therapy would no longer work, and these patients die, because even though you apply the therapy, it doesn't work and they die. This is a huge problem. So research is done in CRIM-negative patients. We think that these are patients that have not one enzyme whatsoever, and they tend to develop these antibodies, and so they die. And to the contrary, there are other patients who are CRIM-positive, and perhaps they do have a few enzymes there, but in theory, and generally speaking, they don't tend to develop this immune response against the drug. And so, although on occasions they do die. And so how do we know if a patient is CRIM-negative or CRIM-positive? Well, we're going to have to see if use Western blot technique to see if there's an absence of the protein. As we said, we're going to have to begin to treat the patient as the sooner the better, and according to we have to see the mutations. So here we can predict to see if the patient is going to be either CRIM-positive or CRIM-negative, although it's not always useful because if there's a new mutation, what often happens, it might not be described already, but you won't know if it's associated either to CRIM-positive or CRIM-negative. So the guidelines say, and that we understand what they say, immune suppress in CRIM-negative patients to avoid the appearance of anti-drug antibodies before we're facing a huge problem. So ever since 2015, 2016, up to 2020, a lot has gone on. So we have to keep on looking further. So literature, what does it say? It says immunomodulation is safe. It means that before you give the first infusion to the patient, you give strong drugs to the patient so that the immune system is weakened so it won't make antibodies against the drug. The guidelines say this immune modulation is safe. I'm a pediatrician for metabolic disease. I don't know how to handle these drugs, but my colleagues in oncology, they say, that's okay. This will be just fine. It'll be tolerated just fine. The benefit might be quite good. So another article from 2018, it's an article from an Australian group, and says the patient was CRIM positive. He wasn't immunomodulated or immune suppressed. He developed antibodies and died. So if this happened to me again, I would have used immunomodulation, even though he was CRIM positive. So even though we decided with all of this knowledge and all of this information that we had we looked at our search in the literature, we immune suppress the patient regardless of the patient is either CRIM positive or CRIM negative. So this is our diagram for our treatment. There was a professor from Duke University who knows a whole lot about Pompe disease, Dr. Krishnani, and she sent this to us very, very kindly. And so the enzyme is delivered every 2 weeks and immune suppressed with rituximab, methotrexate for the first month. As you can see, there are many, many infusions. This is a very hard first month in the hospital with lots of infusions to be able to do this well. Another misgiving, other doubt that arose, and with these treatments, what we did was to use a device so we wouldn't have to put an injection in the patient every time. It was a subcutaneous device. It doesn't hurt the patient, and it's there because it's always there. If you have to infuse chronically, you need to have this. So the colleagues from anesthesia said, well, of course, this hypertrophic cardiomyopathy, this very thickened heart, perhaps it might be a risk that something might happen to the baby in the operation to put this in, and it wouldn't. Maybe we should infuse this peripherally, and that might be better because the heart does improve quickly, and then you could put in your central venous catheter. So it seems logical, but let's again look to what science tells us, and maybe we can find the answer there. Let's look for the best answer. So there was a very good article, a bit old but quite good, 2007, where it refers to 139 patients with a well-documented disease, good clinical trials, which we heard about before. Everything is well documented, so everything was clearly documented, and 139 patients is a big number in Spain. I don't even know if we have 13 IOPDs now. 139, that's a lot. So only 9, that is to say 6%, had arrhythmia or cardiopulmonary failure after the induction anesthesia, and 2% patients died. However, what they did see is that all the ones who had died had a left ventricular mass index of, look at the number here. And it's a very thickened heart, but how thick? This can be checked out, and if it's over 350 grams per square meter, they had this in common. So what do we have to do here? Call the cardiologist and say, hey, this baby, what's the heart like? Quantify this for me. So there were 287 grams per square meter. This was less than the ones who had died. And so also we have to remember that the first month, there was a lot going on. They were infused every 2 weeks, but the first month, every other day, there were lots of infusions, very long infusions, and that tiny baby, 2 months old, tiny little arms. It's very difficult to get the veins. So we had a multidisciplinary meeting. We put everything on the table, and we decided to implant this before we began with the treatment, and everything went quite well. So what is the evolution of patients with this with IOPD? In absence of treatment, it's terrible. This is the survival curve. Here's 100% all alive, and then all dead. So you can see at 10 months, 12 months, 20 months, no one is left. In the absence of treatment, this is devastating. And for some time now, we do have ERT available to us, and this has changed everything. Before, everybody died. Now, not everybody dies. But be careful here, because this is far from being perfect. This is another survival curve with our enzyme replacement therapy. This is radically different. Before, everyone died, but here there is quite good survival. But the ideal thing would be that this survival here at 5 years, the ideal thing would be at 100%, and it's not the case. It goes down, and with quite a few added problems, because this is half of those who are still alive, and they still have mechanical ventilation. So yes, the treatment is very good. However, it's very far from being perfect. So these curves are when we've been discovering that there are other factors which can influence the improvement of these results. These are not the results of how things were done in 2020, for example. So there are new articles which are going to give us more information. This was presented in 2021, and so we are learning about things that we can use to improve this survival. Here's the survival curve, but it's not life and death. It's time when they did not require mechanical ventilation, invasive ventilation. So we look CRIM negatives, immunosuppression, and to begin the treatment as soon as possible. Let me explain this graphic to you. It's a bit busy, but if the patient is a neonate, no enzymes, and if you don't immune suppress, it's almost as if you didn't give him anything. Over here, they're all going to end up with mechanical ventilation or dead. And here, if we immunosuppress, things are stratified, and so depending upon when you begin the first enzyme therapy treatment, if you begin this before 4 months of life, it seems that things go quite well. However, if you begin between 4 and 15 weeks, a bit worse, and then if you begin beyond 15 weeks of life, much, much worse. And notice that this is, if you begin before 15 weeks, this ERT, you will have to do the diagnosis, get the drug. They're very costly. You have to have a commission. You've got to do so many things before you can even begin the treatment. So in absence of a neonatal screening problem, then it's very, very difficult, because you have to give so many things. And if you're lucky enough to do the diagnosis early on and you're at a center that knows what you have to do really very, very quickly, then lots of things have to converge so that you are able to do all of this quickly. And then besides, there's another factor which influences the prognosis. This is an article published at the end of 2021, and this is a scientific magazine. The very good ones have a very important impact factor, and they only admit extraordinary articles, very, very well done articles, and this is one of the articles. This is a top journal. And so in our look at here, we see our enzyme therapy, and it wasn't perfect. We saw that the ERT was not perfect, and in real life, other things have been done, other doses have been tried to see that help the patients improve. So here, this is a survival chart, and in green, this is the standard dose, 20 milligrams per kilo every 2 weeks. In blue, the dose, intermediate dose, it's the double, 120, and the high dose is 40. So it's higher than what we saw in the beginning. So according to the last evidence, the dose at which you treat also plays an important role in how and what the prognosis will be in the long run of the patient. So this happened in 2020, and I didn't know too much about this before 2020, but then chance and luck meant that there's not one without two and not two without three. But anyway, the following year, another patient came, and we were very lucky because it was a very early diagnosis, and the first infusion of enzyme therapy was at 18 days of life, and 1 year later, also very lucky because the cardiologist saw the patient, and he had his first, at 15 days of life, this enzyme replacement therapy was given. So these are our first 2 patients. The first one I said began at 2.5 months, and the next at 18 days of life. 18 days of life. This was published in a communication to try to see if anyone found him or herself in the same circumstances, would know what to do. We followed the same treatment schedule. We used ERT, immunomodulation, and the scrim positive or negative. And we already have heard about hypertrophic cardiomyopathy. And so here we show what we saw beforehand. This is the left inventricular mass, and this is weeks after treatment. And you see that in green it's a patient, and in blue is another patient, but both began with a very thickened heart. But after 20 weeks, more or less, and using ERT, the heart was already normal. And so look here. Don't know if you remember, look at the wall is very thin here. And over here, this was in the beginning, how thick it is. See, look at that wall there. And this responded, so the response was spectacular here. And we look at the motor scale. They were very successful here. This is a percentile of the weight and the height, and we see a scale called Alberta Infant Motor Scale, and these 2 patients were considered as normal within this scale. One even began to walk alone at 10.5 months, which is really something, because any normal child, mine didn't started to walking when they were 15 months old. So this one really began walking quite early, and of course, neither of the 2 required ventilation or any help to eat, which would have happened almost for sure if they had not been diagnosed so early on when they began being a bit hypotonic, and if they had not had this early treatment and get their diagnosis and treatment. These are the labs, and this is also very important, immune suppression. Here we see the IgG antibodies, and these are these terrible antibodies that we're so scared of, because if they're expressed, well, in a maintained fashion, the drug might no longer work. So we measure this carefully, and it's been 0 with our different values. And so my end message, it's important in as much as we don't have a neonatal screening, it's important for doctors to be aware of the important aspects of this disease in case a patient like this appears before them, so they can identify and diagnose on time or in time. It's very important to have disease awareness, so that all doctors should be aware of this in case this baby like this comes in. Not say, oh, I'll see you next week. No, you've got to do the diagnosis immediately and remedy the situation right up front. So if there's a tiny child with a very thickened heart, you just should suspect this disease. And also the fact that the child not have hypotony, you think, Pompe hypotony, even though there might not be hypotony, and this doesn't rule out the disease. They should begin being treatment before hypotony occurs. And you must go fast, because the sooner the better, and we should begin before the first month of life. And as I said before, with a severe disease, with an efficient treatment, and where ideally one should begin the treatment as soon as possible. And the fact that this disease is considered, it should be in the neonatal screening. I think it'd be very interesting as a patient association, perhaps you might have an important voice, and you could do something here with the politicians. I think the complaints from patients are better than what we doctors can say at the hospital, and nothing more. Thank you very, very much. Thank you for your kind attention.
Muchas gracias, Javier. Muchas gracias, Cristina, por las
Thank you, Javier. Thank you, Cristina, for your presentations. I think it's the right time for questions now. If there are any questions with the microphone, please. I'm quite rapid asking questions. I'm even more rapid than you are, said somebody. Concerning the neonatal screening is something that the Patients Association, not only ours, but also from since long we have been working in groups. I would like to know, what do you advise? What do we have to do? Because except Murcia, that is the community that I think has 40 diseases, the other communities are, well, it depends on different things. And the other question, to leave the micro to another one, with concerning the issue of the dosage of the enzyme for the patients. It is quite clear that in the label, 20 milligrams in adults, in some other cases it increases to 30 or 40, but in principle the drug is implemented through cost benefit. I would like to know if in the future maybe there are new therapies, if it's possible that the adult patients we also could have 20 or 30, or because maybe it's going to be better for us. I don't know how you see that.
Vale.
Well, I start with the one of the neonatal screening. It's a problem, I think. You know that in our country we have so many health care services as autonomous communities. So there is an inequality in the amount of pathologies that are screened depending on the autonomous communities where you live. So hence, practically more than half of the children in Spain do benefit from an extended screening, but there are other autonomous communities as mine, the Basque Country, where we have a screening that is extremely limited. So steps are being made at the level of central government and the ministry to try to unify everything, but it seems this is going to be quite slow. And it seems as well that the push from the patients' associations to the politicians maybe could help somehow. The advisors in the autonomies, health advisors in the different autonomies, it could be effective for them, or at least they hear it from several places, from several sides, and from the patients and from the other communities, and this can help. In Ceres, there is a working group in order to try to do something about it. But I don't know if it's only we. I suppose that you are also doing something, that the medical community doesn't reach that point because you have the space that you have. But we also have from our scientific societies, we are also pushing. And so if everybody is pushing from all fronts at the political level, the push of the thrust from the patients, I know that they take into account, I know some associations, the organic problems, etc. Associations have been asking for meetings, asking it in a written manner, etc. And everything is, at the end of the day, we have to achieve that. I can't understand that they don't make the screening of many more diseases as well. So at the end of the day, it's not something that is going to save money. So many patients that you can change their life because you are on time when you find the disease. And from the economic point of view, I also think it's cost efficient. We don't have to bear in mind only the medical expenses for the treatment, or also the expenditure of the pilgrimage of the patients, going from doctor to doctor, the intensive care unit, the cost of the therapies, the cost of parents who can't go to work because they take care of their children. All that has to be also weighed. I can't understand how this has not been extended, but I suppose this is going to happen. But until it happens, we all have to push so that it becomes a reality. And what you said about the dose, what I have said, we shouldn't be confounded. IOPD in the classical infantile form. And in the lithoset form, my knowledge, the dose is 20 every 2 weeks, and with that it's fine, I think. If I give more, maybe it's going to be better. I don't think it's like that. It's not accurate to do it in that manner. Only say that as far as I know, in the adult form, this is not studied if the dual dose would be more efficient or not. This is one of the problems of this therapy, that the more you inject, not everything reaches the muscle. If you inject more, more will be coming to the muscle, but it hasn't been studied. This enzymatic therapy, compared with the one of other metabolic diseases, the dose used is much higher already. So apart from doubling the dose, we have to see if it is safe to use such a high dose. As far as I know, this has not been studied yet.
Hola.
What happens if there is an allergic reaction, or that the patient, I don't know, she didn't finish the sentence. As our colleague has said, the allergic reactions are very infrequent, but this doesn't mean that they don't exist. So it's a problem, of course, a very big problem, because if a patient has an anaphylaxis, an allergy to a drug that is going to save his life, it's a big problem. So if you are allergic to something, to a drug, and you have had an anaphylactic shock that is severe, that is jeopardizing your health, it would be contraindicated to give it again infused in the vein. This would be terrible, not a good idea. But in patients with this disease, and especially in IOPD, the classical form, if you don't treat them, they're going to deteriorate and die. You are between two bad things, and there are good news because there are approaches that can be followed. The first approach would be to pre-medicate, try to give it slowly or more slowly to see if he tolerates it. If it's not so, there is another approach that normally gives good results. Desensitize, starting the infusion at a very diluted concentration. You give very much diluted, so the body, the mast cells, the inflammatory cells that make this reaction are releasing their mediators, and then slightly higher concentrations, and then you put it at a normal concentration. The mast cells don't have anything to do any longer, and there is no reaction. But this is quite, people are afraid of it. It's a big problem, but we have ways of trying to solve that problem. The reactions are quite rare. The allergic reactions are not so frequent. But there are some cases. Yes, there are some cases. I have seen them. I have had one in adults as well. They can be managed, and there are resources in order to be able to do that as well. Medication with safety. But this has to be given in the hospital, of course. Good afternoon. I have a question for Dr. Cristina Dominguez. When you took the fifth papers in the fourth one, I don't know if I understood it well, they compared the use of the miglustat with its efficacy combined in the first generation RT and the second one, if I understood it well. And what the paper said is that it was the same. Basically, in the second generation, to implement miglustat together didn't benefit. To clarify, the therapies, the first generation myozyme, second generation avalglucosidase and cipaglucosidase. In cipaglucosidase, it's the enzyme where we have to add miglustat so that it stabilizes the enzyme, it brings its efficacy. In the paper avalglucosidase, that is another second-generation enzyme, they don't need the miglustat in order to be able to enhance its efficacy, because adding it doesn't change the final result. But at the end, you said that in the second generation doses, they compared the first with the second. They compared avalglucosidase, that myozyme, with avalglucosidase, the second generation one. In that paper, they didn't study CIPA, alglucosidase and avalglucosidase. The second generation is the one that shows that when the glycogen of the tissue is going to be degraded, it's 5 or 5 times more potent than the first one. The second generation is much better than the first one, at least in vitro and in animal models as well. And what you have seen until now, or haven't you started yet? Jordi will tell about that within a while today. Thank you very much. Hello. In my case, for instance, we have the stabilizer miglustat given in a patient who has a high dose of myozyme of 40 every 2 weeks. We started gradually, stepwise, trying to see if the increase of those had any effect. But even with the stabilizer, once they increase the dose, we haven't noticed an important change. As mother, scientific evidence proven, I have none, but I have really seen that my child, has improved as the time went by, where he was taking Myostat with Myozyme. If you go over to the second generation, now I'm in the problem of, I don't know if this is very proven or not, but starting to prove it from the very beginning, a company, if I go over to the second generation directly, they're going to remove the miglustat because it supposes it's better and has a greater efficacy and it is better in the muscle or not. I don't know how to say that. I don't know how it's miglustat added to myozyme. There is no evidence to do that. So starting from that base, now they change the medication and give you one of second generation and give next Myozyme. The idea would be not to add miglustat because science says that it doesn't increase the benefit adding miglustat. And in the case that I have already noticed changes, even when we have to prescribe, we have to trust the studies that have been done with many patients, very rigorous studies. That's what we have to be based on, not on particular cases. When I have to prescribe, I wouldn't add miglustat to valglucosidase or myozyme. And the topic of the literature as to the increased dose in the patient, is it enough supported that it says 40, because my child is in childhood Pompe, but he is already 15 years old. And he's going and go over now to the adult hospital. And my medical guidelines say what they say to Pompe in general. My physician changed the dose because he saw a worsening in the child, so he increased that. But now I fear that maybe it's not well supported by the studies with a specific case. And another physician comes and say, as miglustat is not supported, the dose of 40 is not either supported by the evidence. I'm going to ask, you can ask Javi, I will leave him to answer that question. Your child is 15 years and his child, but it's the severe form of the cardiomyopathy, or what was the diagnosis? He was diagnosed with at the age of 12 months, started the treatment. No, with 12 months they started making the test, and the treatment started when he was 16 months old, more or less. He had a large heart and muscle weakness. He has never been able to stand nor anything. So at the age of 3, he had a relapse caused by growth. He started having respiratory problems, and that's when they started increasing the dose. And after a long time increasing stepwise the dose, we started with miglustat, and both things have stabilized him exponentially. That's the truth. I think that one could say that it's an infantile form. So this paper could be useful for him as well. But of course, this depends as well on the autonomous communities, and it's a very expensive treatment if they want to accept that. The payer can say in the label that it says that, but we're not going to do anything else. Or if there are good arguments, maybe they do accept it. There may be differences between the different communities. Another thing is that when they go over to the next generation, to valglucosidase, probably we have to reduce the dose, start with the lower doses, and always have the possibility of increasing the dose. I have seen people who have made the switch, and people who were with 40, they did the switch and they changed to 20. I would have said that one should have to change to the same dose, and I have doubts in that respect. And when we make the change, let's see how this change is going to be done, the changing of the dose. Yes. Thank you.
¿Puedo hacer otra pregunta?
May I ask another question? One more? Just one more? One more. Could I ask two short ones? Anticorpos they change during the person's life. And if my son, he makes antibodies, and then should we again test to see if there's a variation or if he's okay? You should follow up the level of antibodies regularly, but they can vary. Yes, yes, they may. And with a new treatment, if there is a new agent, should we also have a closer follow-up if there's a change? Yes, just exactly the same. And then I'm going to check that. And I think when you spoke about physical activity, in the case of my son, we're trying to get him to be Rambo. So he's always doing things, physiotherapy, swimming, and passive exercises. I think we exhaust him at the end of the day. I recognize that. But at nighttime, he's just falls. He's so tired. He doesn't really walk much, but he does do moderate exercise. Do you think this is counterproductive? Because I see him so exhausted at the end of the day. Answer: you should maintain physical activity of a certain intensity, but he should never be extenuated. I think that if he's exhausted by the end of the day, you should let him rest sometimes. Okay. But I'm not destroying muscle, am I? Something's not going well. It's like with athletes. Sometimes you have to lower the level. Yeah. Thank you.
Bueno, dar las gracias a...
Well, thank you, Nuria, Christine, and Javier. Don't leave. I have a little detail for you. And now we're going to have 15-minute breaks, and then we shall begin the second part of our meeting, where we are going to speak about, a quarter of an hour, we're going to speak about gene therapy. Thank you.
Por favor, sentamos.
Please take your seats so that we may begin now after our break. If there's one word we're going to be hearing a lot, will be research. This is the main word here. And on this occasion, we will hear from Dr. Iris Ramos, and this is being done in Andalusia. And this is research for the search of alternative treatments for Pompe disease. This is an integral work project by the Pfizer and the University of Granada Center, as well as the Board of Andalusia for Research in Genomics and Oncology, GENIO. So we're going to hear about these alternative treatments. And now we're going to now give the floor to Dr. Iris Ramos. Can you hear me? Yes, thank you so much. As you heard at the beginning, you've heard about how important it is that we researchers be close to the patients. And I would like to thank you for this occasion you've given to our group to be able to be here and to learn a great deal, because obviously we learned so much from these types of meetings. So thank you very much. Basically, we've decided to give a summary to introduce ourselves and our center, our team, our objective, and how we carry out our research. These are our two research centers where we work. We have the Pfizer Center, where all of this began, and now we have a laboratory at the School of Science at Granada University. This is our team. We call it our Pompe team. And I think that you will see familiar faces, Pili and Javi and Paco. He couldn't come here, but he always thinks about you. And then we have new people with us. As you know what happens in Pompe disease. There's a defective GAA enzyme. It's in charge of breaking down it breaks down gluten into glucose, and so sometimes it can't be broken down. And so what happens is that lysosome no longer functions, and so then the cell has defects. The only treatment which exists at the moment is the replacement enzyme, but you know more about this than I. And it's kind of heavy going because patients need to, this needs to be given every 2 weeks. It's costly. It can lead to cause antibodies. It's not the most important problem with this therapy, however. And this drug doesn't traverse the blood-brain barrier, and it's not a definitive treatment. So this dose has to be delivered every 2 weeks. This is why we were considering the use of gene addition therapies to transform these cells, which have this defect, into normal ones. So this would be one single treatment would last for life. It would be a good cure. And so how do we do this? How do we do these preclinical trials about which was you heard about before? You heard before. So we make cells which will mimic Pompe patients' cells, and so we can study different optimizations of this enzyme of GAA in order to improve the secretion of this enzyme, which is produced at the cell level. It's secreted to the medium, and it can be taken up by damaged cells, so we thusly correct the pathology. And thanks to these studies, we obtained, and we published a scientific article, and we did this in a rat model, or a mouse model. And so now we're going to do it in humans so we can go to the clinic. We also work in vivo models in these little mice. And so at the moment we have a Pompe murine model, which is this one over here, where you can see that the hind limbs are more affected, or the hind paws. And so we had to wait a year to see the phenotype of this pathology. So what we want is to reduce this time period so that it reached the patients earlier, and we don't have to have trials that last for several years before we learn about the efficacy of our treatment. So we've designed different animal models which present mutations of real Pompe patients. So this was a mixture between the infantile onset and the adult onset types. So we've been focusing on developing models which mimic the infantile onset Pompe disease. And as a result, we have this little mouse, and in heterozygosis, it only has one mutation, and as you can see in this video, it has a weakness in the legs because this is promising, because when we have two mutations in the same mouse, then we shall shorten the time. This is 1 year, and with two mutations, then just in a few months we'll see this phenotype. Another good bit of news that we have, and it's international funding. Spark Therapeutics to generate these animal models, and Spark has experience by funding projects for Pompe disease. And what does our work consist of? Well, on one hand, we work with gene editing. We have a kind of molecular scissors, and we decide what region of our DNA we're going to use these little scissors, and then in our cut we shall introduce what we wish. In our case, it will be the GAA's enzyme, the productive GAA's enzyme. And on the other hand, we are working with gene editing, and this is a type, these are like little bullets where we shoot our therapeutic enzyme to be inserted into the genome or the DNA randomly, but very efficiently and very potently. We also work in vivo strategy, inoculate directly these tools into the patient, in our case, into the animal model, and in ex vivo treatment. I'll explain this to you later on. The in vivo strategy would be local delivery, where we give the injection. This is where the therapy will go. And so with regards to this therapy, there are various clinical trials at the world level using a virus. It's not integrative, and it has given good results. So on the basis, well, the bad thing is that it's got a series of limitations, and it's centered on the late onset phenotype. It acts locally, and it has a limited uptake by non-edited cells. What we did with these clinical trials was to select the type of virus we wanted to test, and I'm showing you these results. And we did an experiment by applying our therapy, and we measured the time that our treated and untreated mice, how they were able to withstand exercise, the typical thing that mice like to do, running on a little type of this round cage, and so their hind legs got tired very quickly. So we checked our Pompe mice. After the therapy, there had been an increase in the time that they were to withstand running, and the results were rather good. And so also, by using another virus, we measured the strength of these mice when they would grip a bar by using their hind legs. As we saw in the video, they were the most widely involved or affected. And we saw the Pompe rats there in red. We see it red, they lost their grip, their strength, but the treated ones, they were able to hold on, not as well as the healthy mice, which didn't have Pompe disease, but it was rather significant to see the strength and the grip that they had as time went by. And now the ex vivo therapy, what we do here is to modify these hematopoietic stem cells, the HSCs that are found in the bone marrow, they will be able to give to the cells that right lineage to the blood. And so we have to, this is in, with one single edited cell, we are going to have all of these corrected ones. And why are we interested in these cells and above all the macrophages? It's why, because we are going to use them because they will deliver our therapy in such a way that we would extract the hematopoietic stem cells from the patients. We would load our corrected GAA ex vivo in the lab or in the hospital, and then these cells will be reinfused into the patient. We would repopulate the bone marrow, and then they would go into the blood and transport our cured GAA protein to the place where the damage was, where our macrophages or deliverers secrete this protein, which would be taken up by the cells so that there would be a correction of all of the body by using just one single cell type. And this strategy also has a series of limitations, and so we'll have to tell the patient we get the cells from the bone marrow. They have to have a conditioning regime. The efficiency of this editing strategy is limited. There's cytotoxicity, and also in the in vivo strategy, the GAA uptake is limited. Nevertheless, we got good results by using the molecular scissors or the CRISPR system because we have high levels of efficacy and we have not observed cytotoxicity. And by using the lentivirus or the bullets, we've also optimized the GAA structure and we got very good results here. And we're also working on a combined theory, which would be using local delivery and systemic delivery. In other words, we would do everything possible so that these cells, which will reach the entire body, if there's one tissue more affected than another, for example, a muscle would have a little extra boost, GAA in those tissues, for example, that are more difficult to treat. And we're also studying the increase in the GAA receptor level, and this was a limitation that I was mentioning, that there aren't many receptors to see if thusly we can give a stronger therapy, a more potent therapy, and we would improve the GAA protein to enhance the secretion and the capture in the entire body. And so thank you very much for your attention and for your support making this a study possible. Thank you so much. Thank you, Iris, for your talk. If there's a door open for hope, it was opened by the gene therapy for Pompe disease. In 2017, when researchers from Duke University developed gene therapy for Pompe disease, which could improve the treatment used up until the moment to improve the quality of life of the patients with this pathology. And the approach was as follows: to take to the expression of alpha, precisely of acid alpha glucosidase to the liver to get to be able to have a continuous treatment. And so, where is this treatment now? What is being done at the moment? These are questions that we're going to ask in the following panel session. We have Dr. Jordi Diaz from John Walton Muscular Dystrophy Research Center from Newcastle University. He will be our chairman. And we have Dr. Barry Byrne from the University of Florida. We have Dr. Javier Molina and Pilar Munoz from the Pfizer Center, University of Granada, Andalusian area for genomics and oncology, Genio, and Dr. Manuela Corte, also from the University of Florida. You have the floor. Welcome. Microphone, please. Thank you so very much. For us, it's a pleasure to come here to this conference. I have been coming here nonstop since 2012, and I think Barry has been coming longer than I. So thank you very much for your trust. And this is a panel session which we have done these past few years, so some of the things are things you already know about. However, I think that it's always good to review some of these concepts. So by following this format, that we've used other years, what we're going to do, we're going to use some slides as guidelines, and we'll be talking about different concepts. I want this to be very dynamic. I'm going to ask questions of the members of the panel, but you are the ones who are going to have to ask questions. So we're going to look for moments when we should ask questions, but I think it's very interesting that we ask generic questions that might be useful for everybody. But if you have any questions from your particular cases, then obviously you can certainly ask. But I'm not going to speak about Pompe disease because I think you've already heard about it quite a great deal. But I think this slide is very important because we're going to talk about the new drugs that are coming on board. And I have allowed myself to change the program a bit because instead of giving a talk about new therapies and enzyme therapy, we're going to, because Barry has a great deal of experience with this in the United States, obviously, and we're going to also refer to this here. I think it's important that you understand the pathophysiology of this disease. In other words, how does Pompe disease work? And under normal conditions, what we have, and you can't see this very well, do we have a pointer around? Under normal conditions, we have our gene, our GAA gene, which is going to produce a protein, which obviously is acid alpha glucosidase. It's going to, and here we have this, in the end it degrades glucogen. So what happens if I have Pompe disease? I don't produce GAA. I don't produce it very much or in a stable fashion. So it means that I'm still sending glycogen to the inside of the lysosomes. They need it. This glycogen is accumulated here inside. And so these lysosomes are so full that they begin to break, and we have all these little black things you see here. This is the glycogen in the muscle fibers. But the lysosome is very important because this is where there's a recycling of all of the organelles of the cells, the old proteins, the old mitochondria. They accumulate inside here, and it's full of glycogen. The recycling center is full of trash. It doesn't work, so all of this trash is accumulated, and these are autophagic vacuoles, old proteins. They are no longer function, mitochondria that are also dysfunctional. This will lead to a series of problems at the functional level. So with this situation, what therapeutic options do we have? The therapeutic options have been expired. We have enzyme therapy, which has been used for quite some time. I'm sure you're familiar with myozyme. You've heard about myozyme already, so I'm not going to delve into this. Javier spoke a bit about the experience in infantile onset Pompe patients. And so myozyme has changed a great deal. The natural history of the IOPD has changed a great deal. No doubt about that. We all agree about this. But it is true that patients with the infantile type, the CRIM negatives, they might progress, and we see these children when they begin being treated, and a few years afterwards we see some children who are quite well and others who clearly develop a weakness, or this little girl over here, so she needs to have one of these nasal tubes, and sometimes these children progress in spite of the treatment. And so it means we're going to need and require new treatments, and we can speak about new treatments. In the adult form. I'm sure you're familiar with this. It's the results from the clinical trial done in 2010. You see the patients who walked more and they were stable from a respiratory point of view, but those who took the placebo, they walked the same way, but they worsened. And from the respiratory point of view, we know that the adult patients, and this is a question that several of you have already asked today during the coffee break, and after 5-6 years, there's a slow worsening. Not all, but there are 50% of the patients approximately. And after 10 years follow-up, they continue with a certain improvement from the baseline and in their way they walk and in their respiratory function. But it is true that 50% of the patients, they begin to worsen. They begin their decline. And this is important. We've seen this in the registry, which Rafa presented beforehand. So we've got your data because a lot of you are in this registry, and we saw a worsening of the motor function in our patients as time went by. And so now we see this slide. What treatment options do we have before us? We have new enzymes, about which we shall speak afterwards. We have gene therapy, and we're going to speak about that now quite broadly. And we could reduce the production of glycogen. We'll speak a bit about this. And we could also try to improve autophagy. And what is gene therapy? It is a kind of therapy that gives a copy of the gene that we are lacking, and it allows us to, and then so that it can express a protein and, in theory, improve the disease. So what components does this have? It's got the trans genes. It's a copy of the gene which is missing, of a promoter, which means that gene scent is activated in some tissues, but not in all. And it's got the vector it needs. We speak about virus here. This is just to show you a transgene in the human GAA. And in this case, in the case of Pompe, it's a muscle disease. All of the gene therapies tied into the muscle will use the muscle protein kinase promoter. We have high CKs in the levels in the muscles. This is expressed in the muscle and only in the muscle. Importance of the promoter. I have a generic promoter GAA produced in all the cells, all the bodily cells, because my truck takes them everywhere, but I only want the muscle to be where it is produced, where this promoter is produced. So let us follow. Transporters. We have choices, virus or other non-viral transporters. Nanoparticles are being studied, and you'll see why we are looking at nanoparticles. We have retrovirus, lentivirus, many types of virus that are being used. Therefore, my first question for this panel, and for Barry, for example, and for Manuela, who also has experience here, why do we use adenovirus, associated adenovirus in Pompe disease? Why has research begun using this adenovirus and not other in Pompe disease?
So I can go down your list.
Okay.
And so in the very beginning, in the late 80s, retroviruses were tried, as gene transfer agents, but unfortunately in some of those cases for immunologic diseases where they were originally tried, patients developed cancer related to the blood cells that were used with retroviruses. So they were discontinued. Lentiviruses are a safer form of retrovirus, and they're currently used for gene therapy for some hematologic or blood diseases, and are still an option. There is one company, AvroBio, that is pursuing a Pompe gene therapy study with lentiviruses, but it requires having a bone marrow transplant associated with the treatment, because your own blood cells receive the copy of the gene, and then they're re-infused into the body. HSV viruses were used mostly for immunological problems, immunization really, and not ever for a chronic condition like a genetically defined disease. They were used for cancer. And that's true of adenoviruses as well. They were more likely to cause an immune reaction to the virus itself, which in some cases can be beneficial if you're trying to. So there, for example, is an adenovirus expressing the COVID proteins, which is used to immunize against COVID. So this is not good for long-term expression. It's a way to protect against that protein. And adeno-associated virus, we first began studying this now 20 years ago. It is a much simpler, smaller virus that has a lower but not an absent immune responses. So Manuela maybe want to speak to this because of some aspects of the immunity of AAV, but this has been a much more favorable for genetically defined diseases in general. And now there are 3 licensed approved therapies in the US and Europe for genetic diseases using AAV, and none for any of the other types. So this has been the most successful so far. Just kind of briefly touch on each. Do you want to talk about the immunology a little bit of the AAV?
I don't know if there is another question.
There's going to be
right.
time for that.
Yeah, the only thing I want to add is, as you mentioned at the end, is the only one is being used in clinical trials. So we know that is relatively safe. There are some immune responses, but we think we know how to manage some of these immune responses.
Y mi otra pregunta sería para vosotros. ¿Cuáles son las ventajas y los inconvenientes de los lentivirus?
What are the advanced pros and cons of the lentivirus? You have experience with them, you work daily with them. What are the advanced pros and cons of using lentivirus? Can you hear me?
The advantages, well, nothing is perfect. Nothing is perfect. Some things have advantages and some disadvantages. Lentivirus advantages, they integrate into the genome. So what is done is that the hematopoietic stem cells are obtained. These cells from the patients have this error. So these lentiviruses will be inserted. It will modify this DNA, and this copy will be integrated. That it be integrated means that the daughter cells that will come from the stem cells will have this copy. So this is a way of making the correction. So what do you do? In the patient, there's a myeloablation. The cell is removed, and we replace this with the one that is corrected. So the daughters will have the correct copy of that gene. They will be normal cells. So those are the pros. And so the integration, they're put in randomly. There are certain places that have a prevalence that there's a preference there. But you cannot have 100% control over this integration. Those are aspects that need to be improved. And so the adeno-associated virus, the advantage is they integrate well, so they stay there. And we don't run the risk that this integration be in an oncogenic place, because there we would just ruin everything. So it goes into a place of the DNA, which if it going there, it might deactivate expression of an oncogene and might, shall we say, introduce something worse instead of something good. Advantage of the lentivirus with this means that these daughter cells are stable, and they will be producing this new corrected daughter cell, and we avoid this possible insertion in the non-desired site. Basically, what we have just heard is what you're going to see here on the screen. A virus that is integrated, it's going to, we see that there is a cell with its normal chromosome DNA, and then the virus will go in with its new DNA, its gene, and it will stay inside there. And so when it divides, as always happened with the cells which divide, they're always copied. So we saw this before. We will always see it. What's the problem? That there's a risk of mutagenesis, because this is all random. The viruses which are not integrated as the adenovirus, and we have the genetic material, and our virus, then it would leave the DNA outside of the gene material. The problem with this is that when it divides this gene material outside of the cell itself, they don't duplicate, so this is lost. It's a problem that we see at the muscle. So those of you who work with the lentis, you take cells, you put them in a culture medium, and so how do you control the mutagenesis before you infuse this in a mouse or a patient? Can you control this to see if a cell has a lot of mutations? Is this possible? Well, truly, there's been an evolution. The vectors are designed, yes. Safety steps have been taken. We heard problems with Berry and the retrovirus. that on one side there are sequences that are very good to help to express certain things, but when you have to be careful as to what's going to express. If it's close to an oncogene, then you get more oncogenes as well. We use lentivirus, and they're auto-activating because they are able to activate. So we remove the promoters on the sides. The retroviruses have also been reviewed. The lentivirus are much safer, and many of these clinical trials in course right now. There have only been 3 cases reported of toxicity in cases of lentivirus, and only in one of the cases did we see that the integration had something to do with this in one of the clones. And this is a bit complicated to control, as Jordi says, because we cannot infect just one single cell in order to be able to repopulate the patient. We try to get 1 million cells per kilo, 3 million cells per kilo. But here we're playing with the odds, the probability that, that one might have a negative result. So in some of those clinical trials, we do a pre-screening of the integrations. Then we take the little cells before we introduce them to the patient or deliver them to the patient, and then we can see the integration that exists. The problem is that we've got many integrations, and we won't really know if there's one that we can select in the patient because it's particularly advantageous. This is something that is not controlled. That's the advantage that you can have in other situations. There are other problems. For example, the cells might become stressed because they're different extremes which do cause this stress. So you're seeing this concept. It's the dilution of the effect with time. In gene therapy in Pompe disease, it's important to know that if the adenovirus goes to the muscle, it will affect the muscle cells, but unfortunately the muscle is not completely cured. There's no perfect therapy. This will mean that the muscle that could be regenerated and the cells are divided, this gene gets lost with time. A question for Manuela. Manuela, I remember one of your presentations in a symposium where you spoke about how long you thought the expression of a gene could last by treating monkeys with adenovirus. Could you tell us a little bit about this, please? Yes.
Some experiment in primates. We dosed the primates at birth, and then we did a muscle biopsy every month for the first 6 months, and then every 3 months until 1 year old. And what we saw, we inject AV9 carrying the human GAA for the treatment of Pompe disease. So every month we test the GA activity in the muscle, and we saw that it was decline almost to zero of the GA activity within the first year. And probably that's due to dilution, and that's what we'll expect will happen in a child that will receive a dose early, especially with the advent of newborn screening in the United States. So the durability, the information coming from other trials using AAV, especially hemophilia, we think that the durability will be around 5 years. But the problem is even greater when we dose patients in a very early age. So for early onset Pompe disease, that would be even less. And this is a problem for muscle diseases, of liver disease, where there is lots of somatic growth. Also, the dilution might be also depending on the immunoresponses. So there are different the loss of expression of the GAA might be due to somatic growth, but also to the immunoresponses, and that is more an acute issue that can clear the expression of the GAA. So definitely we need to identify a way to repeat gene therapy. So it's not durable forever.
Barry, tú tienes experiencia también en...
Barry, you have experience in other neuromuscular diseases where there has been gene therapy carried out and where we have more information. Is this a problem only with Pompe, or is this a common problem with all of these neuromuscular diseases?
As Manuela mentioned, we have experience now from other muscle diseases, particularly in Duchenne muscular dystrophy, where there are about, in the U.S., 10,000 boys with Duchenne muscular dystrophy, and now an approved therapy for Duchenne in preschool age children, 4 and 5. But in the clinical research experience, about 250 boys have received Duchenne therapy with different kinds of AV. And a small portion of those are now 5 years after treatment. And between the 4th and the 5th year, we're starting to see a loss of the effect, partly because it's not uniformly delivered, even at a high dose, to all the muscle cells. So those muscle cells that remain uncorrected at the beginning continue to degenerate and cause inflammation. In Pompe, there's at least less inflammation than there is in Duchenne, but there is still loss of muscle cells. And a separate problem that we think is very important in Pompe that is not part of Duchenne is that the brain is also affected, particularly the motor neurons that control the muscle cells. So we think part of the loss of muscle in Pompe is the fact that the muscles are not contracting normally because they don't get a signal from the brain, from the spinal cord in particular, for contraction. So it'll be necessary to treat both aspects, and that's one of the things we're very much focused on.
Y una pregunta para vosotros. Hablábamos de
Question for both of you. Mentioned that it's not a problem with elution with the lentis. Is that 100% like that? Or, for example, do you plan on treating with a bone marrow transplant? Would a bone marrow transplant last forever? Could the patient lose these cells? Is there a risk that 100% of these cells not be the ones that are injected, that the patient might recuperate his or her own cells? What limitations do you see in your approach, to your therapeutic approach, with regards to the dilution? Can you mention something about this, please?
Bueno, yo no soy clínica, entonces...
I don't work with clinics, but logically, I would say that the problem would be to get enough CD34 cells. So we're going to have to put in a high number per kilo. So the larger the patient is, more kilos, more need to put in more. So this cell needs to be translated, and then we need to graft it. So the clinicals say we need to make space. And we want to, because you have to have the cells in the right place. So what happens, there might be a selection. In other words, with time and with years, there might be a selection of the cells that have not been corrected. So these are the problems when we obtain these cells. And we need to obtain as many as we can in these clinical trials, for example, and in these deficiencies. We've got the stem cell and expand them in vitro to have enough. And when these cells are expanded, this might affect the capacity of those cells. So these are different aspects. Javi, can you say anything about that? Would you like to add anything else? Limitations? Well, we know from clinical trials that there are bone marrow transplants that might last forever, or at least 20 years. But it is true that when you follow up the peripheral cells, and they're labeled, and there's a peak, and then they reach, shall we say, a plateau level. What has been seen is that sometimes there might be a problem because of a lack of clonality, because we all have blood which is usually renewed, and so we'll have many clones of stem cells producing blood at the same time. So from the clinical point of view, we're very fearful when there are very few stem cell clones. And this might happen if it's not very successful in the bone marrow. So the cells, as Iris said, the stem cells are differentiate to many different tissues, the erythrocytes which carry oxygen, the platelets which help with the wounds, and some macrophages that reside in different tissues, the lungs, the stomach, or the microglia in the brain. And this way it might also help to take the GAA beyond the blood-brain barrier, which is usually one of the problems that we find, to be able to take enough enzyme to tissues which are within a protective area within the cord or the brain. It makes it difficult to reach there. It's good because it protects us, but on the other hand, it's a problem when we want to deliver some drug to that particular area, like the brain. Barry. Barry.
Too, that these approaches, like for many conditions where you might imagine multiple strategies, in some cases can be combined. And in fact, there's one study now combining both a bone marrow transplant therapy with an AAV treatment for Krabbe disease. So 4 children have received this combined therapy. They receive another bone marrow. They don't get a lentivirus as part of it, but that you could imagine that there would be a way to, in fact, combine if the effect were greater.
Okay. Vamos a parar un momento aquí.
Let's stop for a minute here. Does anyone have a question concerning what we've been talking about? And what about exclusion? Does it depend on the mutations, 1 or 2, or is there any exclusion criterion?
So one of the, for gene therapy, at least for the, so one of the exclusion criteria is the level of antibody against the virus. So we are, Jordi presented, or the presentation before presented different virus, but the one that we are using, or most of the clinical trials being used is the AV9. And so one of the inclusion criteria for all this trial is the level of antibody against that virus need to be below a threshold. And the reason is because if there is a present, if we have a high antibody titer, means that we already been exposed to the virus, and therefore when we give the virus for the treatment, there is an immunoresponse and the efficacy of the treatment is reduced. So one of the inclusion criteria is usually to test the antibody against that specific virus used in the trials. So that is one of the most used inclusion criteria for gene therapy.
Mm-hmm.
And you asked about mutations. So in general, the studies have been inclusive of all mutations, but divided by early onset or infantile Pompe or late onset. There's no study that's considered all the spectrum of the disease. So.
Okay. ¿Más preguntas? Okay.
Further questions? To clarify ideas. You, amongst yourselves, you speak in Arameo, as far as we're concerned. Aramaic. Well, I've understood 3 problems. First, safety, that bits of genes are ruined, that should not, the delusion, and what happens as time goes by. And since I have patient, that's just imagine if they say that every 5 years they're going to give you a shot. It might be an option, but then every 2 weeks, for me, that's not a problem. It makes me happy. And then we have the problem that why do you stop? Because of that blood-brain barrier? Has it been proven that the adenovirus, the lentivirus can reach that point? Have you already gone through that problem that we've seen in Pompe, and we're going to have to start all over again because that was another conference where, well, we didn't realize that here also it can be reached. Now to recapitulate in order to see how we can get. We're speaking Aramaic, but you seem to understand everything. I'll answer a few things. Some things I won't because we're going to talk about them later. But the problem for you, it's a very important problem. Actually, is because a key phrase has been mentioned. You developed antibodies. So yes, whether one likes it or not, you develop antibodies. So the response to a second infusion will be much lower. This is a very important problem. So almost all adenovirus, lentivirus, that they cross the blood-brain barrier? No, there are some adenovirus that have been researched. They can cross the blood-brain barrier, and we have spinal problems. But adenovirus don't reach all places the same. Some go to the muscle. They don't always cross over that barrier. This is a bit more complex. And the vast majority, almost all in Pompe, don't cross that. So we were talking about the macrophage. It's not the virus. These are the cells which are able to reach the central nervous system. And this is still one of the limitations. And later we shall see how this will be applied. And then safety. Safety is very important. With regards to the risk of mutagenesis, it's very, very important. And inflammatory reaction, we'll speak about that next. So you can wait on standby, okay, because we're going to be hearing about that next. Following what Laura said, if it's 5 or 6 years for an infusion, we're not worried about how often we have to do that as patients, but their medicine will be advancing and moving forward these next years. Maybe there might be a treatment now, but within 6 years or within 7 years, it not be useful. But maybe there are possibilities that we could be infused, another treatment can be given to us, in other words. So it wouldn't be an impediment. We have to understand that that those are some of the limitations of our current treatment. Yes, there are options. Yes, new things will be coming. I wanted to mention one thing. It's the adenovirus in children. This is very important because an adult doesn't generate a great amount of new muscles. But you know, children, you who have adolescents, know that they begin to grow and they make new virus, and the adenovirus doesn't have that. But dilution is very important, that issue. I shall continue. We've spoken a bit about low response to mutagenesis. This is why all the trials that you're going to see that are use adenovirus. They use adenovirus because why do they have a high infective capacity? And because this triggers a poor immune response. There's not a great deal of inflammation, but there is inflammation. We've spoken a little bit about this. Patients who have defenses against the adenovirus. If you've had a cold, as like I have, you're in contact with adenovirus, and this means that you will probably already have antibodies. So my question for Barry and Manuela, because they have a lot of experience here, what should we tell our patients? What do you tell your patients who are interested, particularly, and who have children, and you say, don't take your child to school? Do you say, don't go out of the house? Do you say, hey, don't use a vaccination? What do you tell patients in general with regards to the possibility of developing antibodies?
So that's a great question, Jordi. And we don't know how the natural acquisition of antibodies occurs, although in preschool it's very low. So it's likely that at school age, the association, and therefore the name of adeno-associated virus, when there's a common respiratory infection, there can be an exposure to AAV. It's generally not the type of AAV that's used for the treatment, though. It's a cousin of the AAV. And so when we measure the antibodies, we can't distinguish between the real thing and the cousin. So, but it still leads to inability to use the AAV. So we have worked very actively on ways to prevent antibody responses and altogether in a group of patients that would benefit from a gene therapy where we wanted to prevent the immune reactions and the consequences of the immune reaction. So it's possible to manage this independently of what occurs in nature. So my answer usually to patients is go about your usual activity. Don't keep children home from school. Don't wear a mask, because we think this is relatively infrequent in children, and it becomes more of a concern in adults, where we know that at least if you use the most strict criteria for acceptance, about half of adults have prior exposure to some form of AAV. Whether that's the right level or not, we don't know. In the currently approved treatment for Duchenne, they chose a much higher threshold for acceptance of treatment, and this has been fine. So this may be that we were too strict in the beginning. You mentioned SMA, the very first treatment systemically was chosen a very conservative level to be included, and now they're mostly infants. But when they're only a week old, their antibody levels reflect that of the mother. And so we found that this is actually safe. So I think we have still to learn more about how to manage it.
¿Y qué ocurre con las vacunas?
What happens with the vaccination? Can you vaccinate the patients? We have adult patients who get COVID and the flu. Can they be vaccinated?
The vaccinations are specific for the disease being protected and not impacting the AAV antibodies.
Bueno, pues hemos visto por qué esto es importante.
We have seen how important this is, and it's important because if you have antibodies, then this is your defense system that works very well. And it means that as soon as the adenovirus goes in, it recognizes it and it activates an immune system which is going to finish off with that virus. There's a question for the panel sessions, is immunosuppressors. We're beginning to have experience with gene therapy plus an immune suppressor. We saw Javier explain that children can immune suppress and with enzyme therapy. So what experience is there in general to treat, to use gene therapy and immunosuppressors so that the patient will develop these defenses and to be able to be reinfused, or in patients who have very high level of defenses, so they can be treated if you give them immune suppression? Thank you.
Yes, so we have, for the last, I would say, 8 years now, we have been studying the use of immunosuppression before receiving AAV gene therapy. We test this in primates, in mice, and we also have data coming from clinical trials, not with Pompe disease. Actually, we do have a study with Pompe disease, using immunosuppression before receiving AAV. And we observed that the antibody, if we use immunosuppression before AAV dosing, all the immunosuppression, all the antibody are suppressed compared to the group that doesn't receive immunosuppression. So we prevent the formation of antibody, and also we prevent immunoresponses and those inflammatory that we mentioned earlier that can cause severe problems in patients that receive AAV. So for our experience, we can say that immunosuppression improved the safety, but also could improve the efficacy of the treatment.
Okay.
I'll add, though, this is an example where the blood cells are very important, and one could even use lentivirus to protect against antibodies both to the protein, to the GA protein for IOPD, or potentially even to the virus itself. And so these concepts, whether it's lentivirus or the kind of mRNA that was used in the COVID vaccine, there may be ways to use these technologies to further prevent, in conjunction with the treatments Manuela mentioned, to actually get sustained lifelong protection against a response to the vector or to the gene itself.
Okay. Eso es una de las ventajas de los lentivirus.
It's one of the advantages of the lentivirus, that you treat cells. You treat cells outside of the system. You're not going to mean immunosuppression. Is that the case? We say, or do you need to do immunosuppression to reduce the spinal cord? But once this has been infused, is it like that? Yes, as these are cells from the patient himself, he will not recognize them as foreign. So they can remove it, modify it. So what our boss likes to, it's called the Trojan horse. And so this cell belongs to the patient. It won't be recognized as foreign, and it's better tolerated. And so that it won't be recognized as a foreign body because it's its own. We have seen that, we've spoken about inflammation. It's important to know that when we inject, there will be millions and millions of viral particles in a half an hour going inside the blood flow, and there might be an inflammatory response. It might be inspecific because so many viruses are going in, and so these are treatments with corticosteroids a few days before the patient gets this treatment, and this lasts for 2 months. We know that later there's a more not such a general inflammation, but it's more highly linked to the gene therapy itself, which is causing a bit of inflammation in the liver. The vast majority of the liver is one of the filters of this virus. A lot of viruses are accumulated in the liver. There might be kidney inflammation and in the bone marrow. The question would be, what benefits do corticosteroids have in patients? What benefits would it be to use an anti-inflammatory in patients who are already getting gene therapy? And when should this anti-inflammatory begin, and for how long should it be given? Thank you.
Okay. So the use of corticosteroids, specifically your question, the learning from this was related to hemophilia gene therapy, so where the expression was intended from the liver. So we're not certain whether this same approach is essential for other targets, like in the brain or the muscle. But nonetheless, it's being commonly used because that was learned from the hemophilia gene therapy, because in the absence of the steroids, the response to the AAV long after it was given, like 1 month or beyond, caused a reduction in the effect. So there's early effects, as Manuela mentioned, or later effects, particularly related to liver. So that's been successful at preventing those responses of inflammatory cells in particularly in the liver. And in the trials being done in the brain, for example, in Huntington's disease or other CNS problems, they were not used routinely, but now some sponsors are considering that inflammation influences the success of the treatment. Even though there was some response, there's a belief that you could have even a better response if the inflammation were reduced. So this may be glucocorticoids, or it may be more specific therapies, because now there are many new anti-inflammatory agents developed for other diseases, in fact, that are useful in the context of gene therapy.
Bueno, pues hemos visto un poquito.
We've seen, we have our adenovirus vector. It reaches specific vectors. It goes inside the cell. It releases its DNA. Then there's a protein which is activated. And now let's speak about what clinical trials are in course now. And I see that it's a bit late now, but I'm going to tell you about some of our results, and then we'll stop for questions. Basically, in Pompe disease, there are two strategies. One is let's go to the muscle or to the heart with the adenovirus. This comes from Astellas, a company, and it looks at safety. And then the other goes to the liver so that the liver will be a production bomb, shall we say, working on this Astellas. And so this is the promoter. This is a phase 1 study, which means that it looks for safety, looking to the dose. The dose increases. Patients come in 2 by 2, and they are given the treatment. And then we see the safety before going on to the following dose. And so we can see the criteria over 18 years of age. The Astellas, they might be patients that cannot walk, and from 2 to 4 patients per cohort, maximum 12. You've seen that the patients have different doses in their syringes, and to the moment, 4 patients have been treated. 4 patients, as you will see, ages between 48 and 66 years of age. 2 received the lower dose, 2 intermediate, and then we're beginning then we got problems. It's relatively frequent that the patients might have side effects. The most frequent one is liver involvement. We've seen this in disease, and it's worthwhile to say that one of the patients developed a neuropathy, in other words, a nerve. This is a disease of the sensitive nerves, precisely after the treatment, which meant that the trial was stopped. It was stopped for almost 1 year because we had never seen that side effect. And now, after This was presented. The patient is safe. He has not worsened. And the FDA allowed us to open up this trial again. It's now recruiting more. Now we're going to treat a second patient in England. And there's a fifth patient already treated in the United States. What results have been seen? Well, we have GAA activity. Here you have the different patients and the changes that have occurred. We don't know too much yet. Do notice that some patients have been treated 2 years, but we're still continuing with these data, which is the muscle biopsy at 120 days. In some patients, there were no changes, and in the others, this went up relatively just a bit, 5–10%. I'm talking about their enzyme level or their activity, and some have stopped with that enzyme. They've stopped with the ERT. It's not mandatory. They can say if they want to stop it or not. 3 have stopped their ERT. And from the functional point of view, the data available in the official data are at 48 weeks. And what we see with the little arrows, they have stopped. There's stability of respiratory function even after stopping. The enzyme, this would be the distance, 6 minutes, 6-minute walking test. This person can barely walk, and he's the one that decided not to stop the treatment. And these 3 have stopped it, and they're stable. This is patient in blue, the patient who developed the neuropathy. And over here, we have a fatigue scale, and you see they're treated, and almost all patients have a certain tendency to improve. The lower the scale, the better, except for this patient over here. And here we see this is the scale of daily activities of daily living, and this one's stopped the treatment. This is just a little bit. This is 48 weeks, and we still don't know a great deal. So what other choices do we have? Well, we have Spark, AskBio, and Spark Therapeutics. The results weren't what they wanted. They're looking for a new vector. Let's remember that the main idea here is to infect the liver, and so that the liver will become a producer. It will be an enzyme. It will produce enzymes, so 24 hours a day. Sticking that enzyme into the blood circulation. So advantages here, the skeletal muscle absorbs this because it's always with the enzyme there in their blood. The size of the target organ is large. It's a blood filter. It's a blood super. Drawbacks. The muscle should take this enzyme from the blood, and moreover, don't know what happens if the patient gets a hepatitis if it takes a hepatotoxic drug. This is frequent antibiotics. They affect liver function, so we can no longer take antibiotics. We don't really know that very well. Can the patient take alcohol? Well, it's important to see how that liver is treated. Here we have more data from another trial. We did not participate in this one, but the data are from 3 patients who were treated. And these 3 patients, well, we see here they have had side effects, a bit of liver involvement. One patient had a pulmonary embolism. And the data that we have come from enzyme activity. We see in the serum, one is stable, 2 go up a bit, but another goes down. In the muscle, they all go up at 52 weeks. They all go up a bit. And muscle glycogen doesn't show any significant changes. There's no decrease at any rate. And from the functional point of view, the patients are stable. This is a 6-minute walking test. This is very important. All the patients here have to stop in ERT. It's mandatory, and they are still stable. They have good motor function. And here are questions for our panel, and questions which I suppose you will also have. What do you think about all this? What do you think about these results? Is this the efficacy you've expected? Did you expect more efficacy from this gene therapy? Or do you think this is because we are at low doses and bringing the dose up, the results might be better and we would see an improvement? What do you think when you see these results? I would like you to tell me about that a little bit. Thank you. I think that these are what one would expect in a phase 1 trial. This protein is not a protein which so generously shares itself amongst tissues. We have tissues in Pompe that are not prepared to absorb enough, so we know that we need to force this system and give them physiological levels so that the proteins may reach the cells which need them in a quantity amount so that the lysosome can do the work. I'm very optimistic, and I think that when we can scale up the dose, that we'll see better results. And particularly, I also think that we are even seeing outside of the clinical levels that we are rethinking the protein, because everyone wanted to use this protein, a protein that was similar to this one, but now we're seeing changes, and I think that with this design, we will see an improvement, but with the following ones, we will see even a better improvement.
Here we go down the line. Oh, sorry. Yeah. No, I agree completely that this concept that in the early phase studies are meant to test safety. And of course, they may not reach the level of most desirable efficacy. But there are two other points I'll make, and then we can keep going to see the high points. But in the first study, the protein is being only expressed in the muscle. I think we now know very conclusively by human studies that study proteins released from neurons that indicate the damage to neurons in Pompe patients, that there is neuronal involvement. Aside from the mouse models that we've talked about for years, we know this is now factual in humans that express neurofilament in the spinal fluid. That's evidence of the CNS involvement. So the muscle-only expression, I think, will not have the full desired effect. And by the same token, expressing the protein only in the liver will not be substantially different than ERT, much more convenient, but expressing continually will not make the protein go across the blood-brain barrier unless it's modified in a way to do so. And this is the point I think is being made as well, that other forms of the protein will be considered over time. So these are important to get started, to know about safety, but there's much more to do to improve the efficacy.
Manuela?
Barry stole my comment. But I want to add that, as he said, these are muscle-specific due to the promoter, but also going back to Lola, that you were asking earlier how to reach the brain. We have done study where we can also dose intrathecally in the spinal cord space to reach the CNS, especially for adult patients and not babies. So there are ways to reach the CNS, just to follow up with Barry's comments, by changing the promoter and by changing the route of administration. Instead of doing IV, which is very hard in an adult to reach the CNS, we can also use other route and go directly in the safely. It's been done for many other trials in the space in the spinal cord.
¿Preguntas que tengáis? ¿Sigo yo?
So I'll continue. One of the things that I always mention, are we measuring the patients well? Here we're repeating scales. They're always the same, 1 6-minute walking test and forced vital capacity, and over again since 2010. Is this what we should be doing? Are there better ways to measure these patients in these trials with neuromuscular disorders and diseases? Thank you.
Yes, I think there are better ways than the 6-minute walking test. There are several other tests that we've been doing this morning and yesterday, but there are many others. The difficulties is that there are different phenotypes, and so it's hard to capture exactly what is changing. There are so many things, and the patients are different. But all your work relating to the MRIs is also another outcome measure that we can use in parallel to functional outcome measure. And so using biomarkers, such as the MRI, to predict some of the changes from functional outcome measure. But definitely the 6-minute walking test might not be the best one. And there are other tests that can be used.
Debemos suspender.
Should we suspend enzyme therapy in these trials? What do you think about that? Seeing the results that we have, do you think that we should stop the enzyme therapy for these patients, or should we keep on using enzyme therapy until we get better results? Thank you.
I think one way to address this to be certain is not to treat all the patients the same, other than the genetic therapy. So one way to address the efficacy of enzyme therapy is to, in a blinded fashion, stop only in half the patients and not the other half, and or switch between giving and not giving the ART, because now we, in addition to, as Manuela said, these other tests and biomarkers like imaging biomarkers, there are now even better biochemical biomarkers, like studying the spinal fluid neurofilament or the blood glycogen or the muscle glycogen, direct measurements either by MRI or by new techniques that are very precise. So I think you can really answer this definitively by some patients continuing on ERT and some patients stopping, but not revealing who gets what. And that's the only way to be sure there's not a treatment effect where the expectation is, oh, I'm getting ERT, I'm going to do better or not. So this is the challenge, as opposed to withholding ERT, which is the standard of care, is also hard. You can't really do that when you're not certain of the effect of the treatment that's being studied. So I think it's appropriate to continue ERT, but to understand whether it's really impacting the outcome by, at a point, discontinuing ERT, because the gene therapy effect continues. The ERT effect is in fact not even more than a week. So it should be possible to measure if the blood or an imaging study helps us determine the glycogen levels, which is the real pathology, right, as you explained.
Y tema dosis.
Now the dose, should we increment this? The problem might be those, can we increment this dose out more and more and more? Or do you think that there is a ceiling, shall we say, with regards to, with using the adenovirus? Thank you.
Oh, I can comment. I think we've reached the ceiling of the current products. The good news is that there are better products that have been developed through very clever technology of using artificial intelligence and machine learning to evolve the AAV to target muscle cells or brain cells or heart cells. So there are now new forms of AAV that are between 10 and even 100 times better. So one doesn't need to increase the dose if you improve the function of the AAV. It's just the challenging part of that is that every time you make a change, you start in the beginning again. So no, we shouldn't increase the dose of these products. We should take the challenge of improving them.
Y con el trasplante de médula.
And with the, what about a transplant, a bone marrow transplant? What can you say about that? The fact that when you establish a gene therapy protocol and there's going to be a stem cell transplant, you always have to make sure that you're going to have a backup transplant in case the first one fails, because it's not if you lose the capacity to produce blood, you're placing the patient in danger. This is a safety measure, and this is something that's always included in the designs of gene therapy. There should always be a relative who can help give bone marrow if it's necessary. Barry, I have a question, a clinical question. It's why do we not have, or why do companies, why do they not use gene therapy trials in children, in infantile patients? And if you were to organize a gene therapy trial in these children, how would you design this trial? And then the infantile patients, you can all answer this if you want. Thank you.
Okay, since you called on me, I'll begin. I think it's a very important question because, in fact, ERT was first used in IOPD because it was the question of survival was relatively more obvious to answer because it's a yes or no question, and this is why it's been difficult to have a definitive study in a later onset disease, because does it matter, is it 25 meters, is it 50 meters, and what matters to patients in their lives in terms of improvement in walking distance or breathing function. So I do think that a infant onset study would be more definitive in Pompe, but the challenge is that the immunology is more difficult because many patients make none of the protein. It's a more rapidly progressive disease, and the standard of care is ERT. So back to the idea of, like, if you were to do such a trial, everyone would get ERT at the early diagnosis. They would receive the gene therapy prior to 6 months of age, and then half of them
with immunosuppression.
With the immune suppression, because this is very common now in IOPD, and then half would stop and half would continue, or maybe they would even switch, and then you would know by 1 or 2 years if the ERT mattered, because if you stop and the imaging markers or the blood markers or the clinical development are unchanged, the ERT wasn't doing more than the gene therapy alone. And this may require a muscle biopsy, it may require a blood sample, but this would be one way. And that, I think, would also enable a better study in LOPD, because the changes are much slower in LOPD. And if you saw an obvious effect in the infants and determined an effective dose and route, as Manuela says, where an IOPD is almost certainly needs the brain exposure as well as the muscle, then this would be a guide to but if I was the head of Sanofi, that's what I would do, but I'm not. So.
¿Alguna pregunta?
Any questions? Manu, do you have a question? I always have questions. I cannot avoid that. That's the way we can learn. With regards to the dose and the gene therapies trials and all, which is easier there? What about the liver biomarkers and them going up? How much do they go up? Because when I began my treatment, they said 100, and 100 is nothing. It's nothing. The hepatic liver levels they're not, it's not that they might be a little bit high, it's that they go up with regards to the baseline level. And so, and you can usually control this well with corticosteroid. If the corticosteroid dose goes up in gene therapy, you give a corticosteroid for 2 months, then you stop, and then when you stop, then you see how the liver enzymes go up. This is usually controlled well with the corticoids. It's not a fulminating hepatitis, at least the patients that I have worked with, but no problem. When I began with Pompe in the hospital, I was a child and I was with the liver patients. No, it's over the levels before the patient is infused. So now the other trial of Astellas, it's true that we know that it was stopped. I would just like to know the timing there. Will phase 2 begin? It's a concern that all of us have with these phase 2 trials. And those of us are here and we have Pompe and we're worried about the timing. How long will it take this phases 2 and 3s to finish? Because, or will it just stop there? It's phase 1, 2B. They're getting data concerning the efficacy. And so now they're going to infuse the 6th patient. They've increased the cohort from 12 to 16 patients now. In the trial, they're opening up centers to recruit patients. Astellas is the only one that is active and recruiting patients as far as I know. I think Barry might know about another one. But as now that they're not with the 6th, I don't think it's going to be forthcoming quite soon. With the data that we have concerning safety for now and efficacy, we cannot think that within 5 years that the gene therapy will be approved for Pompe. No, I don't think it will be like that. I think that it will take longer. I think there will have to be a phase 3, and the regulatory agencies are smart asking the companies to demonstrate security or safety and efficacy, because right now what we have is at 48 weeks, the patients are stable. We do not have data 2 years afterwards. This is crucial because you can't approve a treatment that's cost millions after only 48 weeks follow-up. What happens if 6 months the patient begins to worsen? You'd have to pay $2-3 million for an infusion. Well, now the prices that are being looked at are $2 million per infusion in the bone marrow. Anyway, who's going to pay $2 million for an infusion for a treatment that after 48 weeks the patient will worsen? This is important. You have to put that into the equation. So I think that it's going to take longer. I don't know what other people's opinions are, but I think it's going to be a bit longer before we have an approved gene therapy for Pompe disease. Barry or someone else from the panel is more optimistic than I.
Well, there is one reason for optimism, because I think you're right. The clinical findings, I mean, number one, in any gene therapy, we have to know that the treatment actually can reverse an effect that is present at the time of treatment, and we're not certain of that, even in Pompe, that there may be some effects that will not change, although I do think we should ask for more than being stable. I think that should be the objective, is to actually gain function. I don't know if it will be to the level of a young, unaffected person, but I think that should be the requirement. But it will take time to figure that out, but the FDA at least has opened the door to an alternative way to get authorization and gather that data. And in the Sarepta study for Duchenne, they've allowed a concept that is very relevant to Pompe and all rare diseases, frankly. It's called accelerated approval. This doesn't require multiple clinical endpoints in a placebo-controlled trial. It requires one clinical measurement and a biomarker. That might be imaging biomarker. It might be as simple as glycogen measurements. If those were dramatically changed by the treatment, I believe the FDA would authorize a Pompe drug. And it's not to say that that's easier or less stringent. It just will be faster, because we expect those changes to occur, honestly, immediately. Within 1 month, we see in animals, glycogen is normal. And so if that were the standard for approval, a trial could yield a drug that would be more widely available to allow for the real-world study to understand the clinical efficacy and the longevity. But the better other clinical outcomes Manuela can mention, I think, will also help more sensitive measurements of function.
Vale. Hay una pregunta por ahí, ¿verdad?
Any questions, please? Yes. Good afternoon.
Is this just a matter of time?
He's speaking in English.
You think we will have at the end, I don't know, in 10 years, because the data I've seen on the screen is we are very far of finding a solution, in my opinion. I don't know. What do you think?
Well, this approval related to accelerated approval was in the regulatory science in the world of regulators in the U.S. and Europe was a fight between the conventional thinking and this more new concept that is it's derived from new legislation in the U.S. called the 21st Century Cures Act, that allowed for the voice of the patient to be understood. So this is where you all are very important in saying what do you need as a patient community, and these pathways that take advantage of new technology. So this only was approved 3 months ago. So this will take some time to filter down to other studies and for sponsors to have confidence that that's their approach, that they have to design a study in a way that depends on the surrogate endpoint and not only on the conventional measurements. And today, no sponsor, in 90 days, no one said, okay, this is what we're going to do, change our thinking. They're still thinking the way the regulators thought 3 months ago. So now there's I think that's an opportunity. You want to comment?
Well, I was just commenting that in late onset Pompe disease, the progression is very slow. So we can see, so it looks like there was like stabilization, but we really, as you mentioned earlier, we really need to wait a little bit longer to see if it is really a stabilization or there could be an improvement, or is just a natural slow progression of the disease, which is 1-2 points that, so that's why I think sometimes the biomarkers might be more predicting of a change than a functional, because especially in late onset, it might take longer to see a change, which is different from early onset, where we will see a greater change on a functional outcome measure.
Sí, sí, pero volviendo ahí, al final hay...
So in the end, and with these studies, there are many barriers that we have to jump over. We don't want to go to the spinal cord and antibodies for AVV, 8, 9, 10. So in the end, I don't know if I'm a bit depressed, but I see that there's so many things, and it's very, very difficult to have everything. I know my question isn't easy, but in the end, maybe it's my intuition, because for now I'm seeing how things are evolving in other fields, but at the end of the day, these are, well, everything is thrown away and we're going to have to start all over again and start from zero? Or do we know that maybe, I'm not talking about 5 years because trials take 12, 15 years, but in 20 years, do you think that gene therapy will work? We have to be optimistic. Why do we have to be optimistic? Gene therapy has been approved in Duchenne's, and there are clinical trials in Pompe. 5 years ago, there were no clinical trials for Pompe. This is a big change. The fact is that research is going on. When one investigates and does research, problems are always found. And we can't say, oh, great, everything is just going to be wonderful. No, we don't want to deceive our patients. No, not in the least. And this is a presentation so that you will realize how complicated all of this is. This is not easy. But I think we must be optimistic because there's a lot of research going on. There are many companies and pharmaceutical companies that are behind these clinical trials, and they are looking for a way to resolve these problems which appear. So the patients always say, when will there be a treatment? We cannot answer. If I say 3 years, in fact, what am I based upon? Nothing. I'm not basing this on anything. My feeling is that it's going to be fast. Well, we'll see. Well, I think we've got to be cautious and prudent and patient. And the most important thing is that all this information that we are collecting, it will be useful to develop better therapies and more effective therapies. So in this sense, I think that the fact that there be approvals in these neuromuscular diseases is good because it's also good for Pompe. Any other questions? This is the last question because if not, we're not going to finish on time. You go ahead with your question. My question is, we're speaking about new therapeutic options, gene therapy, genetic therapy. I've been hearing about this for a long time. We're speaking about the fact that it's going to take a long time. So my question is, do you think that in these 5 years, there is more research and that this enzyme therapy will be improved? Well, this enzyme replacement therapy, well, there's nothing new with this. Well, shall we talk about enzyme therapy to link in with something else? Did you want to say anything? I'd like to say that we should always have hope. We're not just talking about lentivirus and AAVs. My colleague said we have gene editing specialists met in gene therapy in Europe, and they're stressing the fact that gene editing can correct and control a bit what you were saying. And where do we insert this gene? And this we have to correct the mutation. We need to correct this. There are different techniques for gene editing, and it's not just 2-3 lines here. No, there are lots of open fronts open. So we see that we can use different tools here. So there are lots of things opened up. We have lots of fronts. I think it's important for us to clarify the new therapies. And when we talk about enzyme replacement therapy, there are two new enzymes which are already coming along, and one is it's called NextBiodyme. It's called, you can see it up here on the slide. This is a second generation enzyme. If you see we've spoken about mannose 6-phosphate and how important this was because it took this enzyme inside the lysosome. This is myozyme, and this is alpha-glucosidase alpha. And so here, the data that Sanofi has that has showed this, that cells in culture reduce glycogen more so than this. And in animal models, it penetrates into the muscle better. It reduces the glycogen than the older drugs. So using these data, these have been different clinical trials. And so I just wanted to mention some of the results that we have today with this new drug. With the first clinical trial that was done, we presented this here. And so 100 patients were included. And then we see 20 milligrams per kilo myozyme, and 51 received this alpha-glucosidase alpha. And the follow-up, you can see here, 145 weeks. And then there was an open phase, and these patients have been followed, and then we see those who got myozyme, we're seeing the results, and they've been followed up for a rather long period of time. As you can see up here, the trial has already concluded, and the company is now looking at all of the data acquired. And so I think it's important for you to see this chart here. This is the forced vital capacity. And this, everything that is in, over here, orange is with myozyme, and in blue it's a alpha-glucosidase. And so notice here, those who got alpha-glucosidase alpha, well, they all improved. This is very important. We see an improvement with the new drugs, and this is important to mention. And so 41 weeks, we see that the differences were almost significant, but they didn't completely reach significance. This meant that the trial and the main objective, which to show superiority of the new drug, was not fulfilled, but all the patients change. And so basically what we see is that with time, there's good stability of the vital capacity. Well, inspiratory, expiratory pressures we again see, and I think it's good to look and see that patients do improve with time. And basically, we see that with this new drug, they're stable and they improve at 145 weeks. And so we see 7% improvement in the MIP, and I think it's 17% in the MEP after this certain follow-up period. And at the motor level, what did they see at the motor level? They saw 49 weeks. This is the distance in the 6-minute walking test. The distance, well, 6-minute walking test. You see that there are important differences at 49 weeks, and then the changes are stable. Notice that over time, they don't improve more in how far they walk, but they are stable. And here you can see the strength here in the lower limbs, and then at 145 weeks, you see stabilities with these values. And you see the quick motor function test, which Manuela mentioned, and we see an improvement in the patients and stability at long time after 2 months. This drug has been approved, and it's going to be marketed. It's almost ready to be on the market, and it's going to be a drug that you will have as a choice. What's the other drug? We heard about this before. It's cycloglucosidase. It's from the Mycus company, and this is a drug which is given with miglustat. It's a chaperone, and so it means that it's in the blood longer, so the muscle can be exposed to this drug for a longer period of time. So with mice, this is a naive mouse, glycogen, and this is treated with a combination, so you can see that glycogen improves. And so based on this is a clinical commercial development. There have been a series of trials. Propel is the phase 3, And at long term, we see that this is a more difficult trial. Why is it more difficult? Because in this case, as in the previous one, all the patients that went into this had never received the treatment. They were de novo patients. They had never, ever received any treatment. But there is a bit of a mixture here. Some had received it and others had not received this treatment. Okay? So if we go little by little, the patients who had not had the treatment, in orange, you can see they took myozyme, and blue, those who took glucosidase. And then what you see that there were no differences after 52 weeks, the 52 first weeks, neither in the 6-minute walking test, where there was an improvement, in fact, neither in the forced vital capacity, where in both cases there was a worsening in spite of the treatment, which is a bit difficult to understand because it's not what we had been seeing up until now. At any rate, we see that by changing to the new drug, after that time period, the result was about the same. There are no important differences in a de novo patient, where they do see patients that they have seen patients who had already received the treatment. And notice the 6-minute walking test, there was an improvement with myozyme. Although this was not significant, the same thing happens as those in Sanofi. The trial didn't fail because there were not significant differences, but with time, there was stability in one or the other arm. Here you see the forced vital capacity, where the patients with the glucosidase are stable, and the ones with myozyme, when they go down a bit and when they change, they are still stable. So the results are fine. So it's worthwhile to say that these are results at 104 weeks. So in 104 weeks. So I have to say that we don't have 3, 4, 5-year-long results. We don't know what's going to happen at long term. This is kind of the real life results. I don't want to just stop here. And as we never speak about the infantile patients, there's another trial called Mini Comet, and we're learning about things here where there we see the infantile type who they received the aval glucosidase alpha, and so we see that there are many arms. Patients have received 20 milligrams per kilo every week, and 40 milligrams per kilo. Excuse me, the speaker says every 2 weeks, and then 40 milligrams per kilo, and then every 2 weeks, versus myozyme 40 milligrams per kilo per week. So Sanofi has tried to use multiple doses and regimens, but it's a bit difficult to know to reach conclusions because the number of patients is relatively limited, between 4 and 6 per arm. So just a bit for you to see that there were no side effects that should be underscored, and long-term results in the mini comment knows that the heart rate is down during the 97-week period. And notice these scales here, GMF and the quick motor function test, which are functional tests, and notice there's a certain stabilizations of the patients who were treated here. And here we would have the level of the biomarkers, the CKs, go down. And notice this scale. We also see in the development scales, and depending upon the dose, there tends to be an improvement and stabilization of the patients with time, and this depends on the age they were entered into the trial. So what data do we have from the real world? Because in Spain, we have 3 patients with who had to leave, and then we see what we have in England and in Wales. We have the infants. We have 20 patients who have been treated with aval glucosidase alpha. No patient has been treated with glucosidase, and these data come from patient stability, and we still do not have enough data to make any confirmations. And we have 183 adult patients in the registry, 21 not treated, 72 myozyme, 41 aval glucosidase alpha, and 46 glucosidase. And so we are collecting data to be able to say what is happening with these patients. So we do not have any medical guidelines about how to apply these new drugs. We're working on this here in Spain with Christina, and we're going to have a meeting in order to have a new medical guidelines, and you've seen before that we want to have new guidelines where we begin to talk about this and see how to at least change. My personal experience is there are no side effects when we change from one drug to another. This is important also for you to know. I haven't seen any important side effect. We have to broaden this sample because just 6 in 2 patients in 2 trials. But de novo patients, there are no problems here of CEPA and myozyme, and differences with Aval and myozyme, well, the ones that I've showed you before on the screen. Patients who have already been treated well, a patient who is worsening, I think we've got two therapeutic options, and I think everyone, if you're worsening, though, you want to try a new drug. And it's coming. Stable patient. What to do with a stable patient? We do not have the answer. I don't really know what to do with a stable patient. We don't really have much long-term data. If we see, remember the initial charts I showed you, 5-6 years? If we had long-term data by showing that stability is maintained, then this would be a good reason to change the patients, but we don't have any for now. What we need is to see how do we perform our follow-up. This is very important because I want to give you a message here. We, up until now, have not had many therapeutic choices for our patients who have genetic neuromuscular diseases, and now we find a disease where we're going to have 3 drugs. So I think we've got to have common sense. If I am treated with myozyme and I go on to the new one, THEPA, for example, at 6 months I can't go back and change to another drug because I say, oh, this is not doing so well. Well, I'm going to change all over again. So it's 6 months. Well, this isn't doing so well. I'll go back to the first one because this would just be a mess. And so, but the European guidelines are going to come out soon, and they think that a patient should be under follow-up for at least 2 years with a new drug in order to be able to see if there's stability or not, or if there's an improvement or no improvement or worsening. And this is very important. I don't know. And actually, I'm going to go to the panel. Barry, do you have experience with these drugs in the United States? Yes, no? Do you want to make any comment? And also, I'm going to give the floor to Christina, who is here. And if you'd like to say anything with regards to what you think about these drugs.
Yeah, we've had patients in all of these studies, and as you pointed out, that leading to their authorization, they were shown to be no worse than myozyme or lumazyme. So they haven't had sufficient magnitude of effect to see a dramatic change. And I do think there are subtle improvements, for sure. But it's not as though one is dramatically superior to the other. So it is appropriate to consider trying, and because each individual is going to be different. So I think your recommendation is a good one. To those that have no improvement on one therapy should investigate the other one, but like you also said, we have to stay with that long enough to show if it was beneficial. I think one thing I'll make a notion of, though, is that we will see increasingly, like in many other therapeutic areas, the combination of different products, not 2 different ERTs, but 2 different approaches, ERT in conjunction with gene therapy, or gene therapy in conjunction with a different small molecule that might affect glycogen, or other ways to protect muscle cells from degradation. So these combinations will be tried until there's an optimum strategy, and this will presumably go on forever to continue to improve outcomes. So it's not going to be there's one immediate goal. This is a continual goal to improve outcomes so people can live a productive life.
Okay. Manuela.
No, I was just commenting on the, adding to the Barry's comment regarding combination of treatment. We should not forget about exercise, because the best way to maintain the muscle is with exercise. So I like Lola that Ivan is tired at the end of the day because he does so many things, but it is important if we replace the gene by itself doesn't do everything, or the enzyme replacement therapy doesn't solve the issue. These are not cure. I believe the combination of different methods, including exercise, are important.
Cristina, ¿quieres añadir algo?
Christina, yes, thank you very much, Jordi. I think that I agree with everything you've mentioned. These are two drugs which in the clinical trials have not been able to demonstrate superiority with the current treatment, but by seeing the results in the animal model and in vitro, which potentially we see it's possible that at long term the effect would last longer than at the moment. And so I'm optimistic here. However, I think it's absolutely necessary to have real-life data. We need to have a homogeneous follow-up, all of the doctors with all of the patients that we're treating and those where we modify the treatment. We must collect this information because we're going to have to analyze it with a large number of patients to see which really works better, which of the three is the best. And it's absolutely essential to have a good follow-up with data and then analyze all of these results, because right now we really don't know the algorithm to be used with these patients. And I agree that a patient who is stable, and I don't know if I should modify, I wouldn't know if I'd modify the treatment or not. I don't think we have information enough here. Are there any questions? Yes. No, we haven't seen any. We haven't seen any. This is a result from all the entire group together. So we see that some patients worsen and some improve. There's a bit of everything, but the group, well, there's an improvement with both drugs, and that's good. That's a good result. The drugs do work, so that's a good thing that they do work. Microphone. No, there's no criterion there. In other words, this is why we're going to have to discuss the criterion that we shall use to begin one treatment or begin another with the current evidence. And so things are a bit complicated because these drugs do work, and there are some things that we have seen here in the de novo patient. I also have my doubt where sometimes it's a bit more complicated. And we're going to have to see what we're going to do. It's very difficult to give you an answer to use this one or to use the other because we do not have enough information about this and in order to give you a recommendation. How long do you need? Well, we need years. We need years and years of patient follow-up. 3 years or, well, if you want to have 5-year-long data, remember when we saw the curves. The curves, we saw them after 5 years. And so now we've got patients in trials who have been followed for 4 or 5 years in all. And I think that we'll see the end results that the companies are going to handle, but we need real-life data. This is really important. We've got to really collect our data well. And what do the national healthcare systems think? With the 3 treatments, are they being funded or not? What is the cost of these 3 treatments? I don't know that. No one talks about that here, but, well, I think that there's no problem here. I don't think that there's going to be a problem. As far as I know, the funding systems will cover the cost of these drugs at the European level. They've been approved, and I think it's just a question of time. And I think that they will be funded in Spain, but I don't think there'll be any impediment here. So I know that you're tired, and Mano, would you just give me 5 minutes? I'm going to talk about 2 quick things because I think it's important that you know that there are more things that are on the pipeline. Well, glycogen is formed inside the muscle fibers, and it goes into the lysosome. But one of the issues is that if we make glycogen in a normal way, and we do this with an enzyme called glycogen synthase, there are inhibitors of glycogen synthase, which are specific for the enzyme which is in the muscle to reduce the amount of glycogen that is produced inside the muscle. There have been a company called Mace Therapeutics, which has looked for drugs to inhibit this enzyme. And you see the results in mice, where a combination of their therapy with myozyme, in this case, was more effective to reduce glycogen. And this is the knife animal, and this is enzyme therapy. Here, the drug all by itself, and here the combination. It reduced in the twin, in the in the different muscles. There are a series of trials and studies in healthy populations to see if this is well tolerated. That it seems that this is well tolerated, but now they're going to start a phase 1/2 trial. So now we're in an important socioeconomic moment because Sanofi bought Mace Therapeutics. It's in the process of buying Mace Therapeutics anyway, and it's committed to continue with this trial. So surely in these coming years, the sooner the better, we'll have a new clinical trial in Pompe disease for combined therapy, enzyme therapy, plus this drug, which reduces glucogen production. We'll see if it's effective in patients or not. And now we've spoken about crossing the blood-brain barrier. And this is what you mentioned before, Lola. So we know that in Pompe, there are alterations here with this barrier, and in the brain, we see the MRIs of some patients with these little white areas which show brain damage. And the blood-brain barrier here, it's very important because it protects the brain. That virus and bacteria do not enter the brain. This is fine and dandy because if not, it would always be dying. And here we see that the problem is that it's very costly for a drug to go in. It's very difficult, in other words, it's very, very difficult for it to go in. And so we know that the transferrin receptor is a normal molecule. It's in the body. It's expressed here. But they have developed an antibody associated to the enzyme. Basically, it's a transporter, the carrier. It's able to cross the barrier and go inside the brain. So not long ago, in a conference last year, they presented the results in mice treated with this new treatment. And what you will see here will be glycogen, okay? Glycogen inside the brain neurons. And here we'll have myozyme. This is a vehicle not tried. This is myozyme. Doesn't do anything. It doesn't cross over the barrier. Myozyme with antibody goes down. This doesn't go in either. This is alpha-glucosidase alpha. And with the antibody, it does go in. And here you see the spinal cord, and you see a drop in the glycogen. Not only this, but also the entire degeneration process inside the brain, and the cord of the patients improves. And we have this new combination. It reaches the heart and the muscle. So with this new drug, potentially speaking, we could kill two birds with one stone. So it goes to the muscle and to the brain. And tests have been done in mice, and we'll see if this reaches clinical trial, and then the treatment, and then for everyone, people who have infantile patients, this is very good news, the fact that we begin to see options to be able for it to go to the brain. This is my last slide. And I think that we're out of time completely because we should have finished at 8:30. It's 8:50. And again, thank you ever so much. I'd like to thank the panel for the speakers and to everyone who's participated. And thank you for your invitation and for your trust in inviting us back every single year. Thank you so much. First and foremost, thank all the speakers and your cooperation with the association. Many of you come every year, and we appreciate this. We appreciate this very, very much. We are in contact throughout the year. Don't leave because we're going to have a little detail for you. Sandra will mention this, and then if I have any doubts, I'll just ask later. So thank you very much.
Llegamos al final.
It's now the end of our first day here of our conference, an intense, long day where we have addressed many, many issues of undoubtable interest for people with Pompe disease, their families, and also for the researchers. Thank you to all of the professionals, the doctors, the researchers who are with us and who have helped us shed light on our questions and questions related to the daily lives of people with this disease. Before we conclude this meeting, we would like to render homage to Raquel Parrondo. Raquel Parrondo is the rights are Pompe and Pompe. It's a story that's made us very happy with the children when we have visited schools, and Pompe is a child story which talks about the daily lives of children with Pompe disease and their parents. And so we've had workshops in schools. With this story, we've reached more than 5,000 students and their families. And We're Patients as a Project of the Year has been an award because of the disclosure of rare diseases. Thank you, Raquel, for writing this beautiful story. So please come forward, and we're going to give you a little detail from Maite, our Vice President. Well, she's saying thank you very much. She's saying thank you, even though you didn't use a microphone. Something else I'd like to mention is that we've had a detail with all of the speakers, and we're an association with a rare disease, and we thought that on this occasion, these little details should be given to association of people with a disability. It's the Occupational Center Jose Portero. And I think that we would like to show that we are inclusive, and they've, so I wanted to mention this. And now, thank you very much to you for your participation. We shall adjourn our session today. We will return tomorrow, all ready to start again. There have been modifications in the timetable for our program tomorrow. So very quickly at 9 o'clock, we'll begin with Positive Attitude from Fabian Villena. 10:15, Home Therapy, Carlota Ranz. 11:15, Evaluation, Respiratory Evaluation, Dr. Ana Hernandez for patients. And at 12:30, Maite and I will talk about the association, and there might be a surprise, one surprise or another. Let me remind you that now we have our dinner for associates and speakers. Have a happy evening, and thank you very much.